Good evening, everybody. I welcome all of you on the second day of this aesthetic gynecology workshop. I know it is generating so much of interest and curiosity, and even though it is an upcoming branch in gynecology, I think all of us have realized that it is very important because quality of life for a woman matters a lot, because she really wants to have a good quality life in beyond 40 or midlife. So I welcome you once again, and today's program is again going to talk about vulval dermatosis as well as the non-surgical and the surgical part about that. And then there is a revision of the previous day which will be done by Dr. Ragini Agrawal. And also there are Botox, filters and pills, PRP and stem cell therapy. And I welcome all the speakers, that is Dr. Natasha, Dr. Gunjan Gupta, Dr. Varsha, Dr. Vidya, Dr. Mayuri and Dr. Milinsha. And I think counseling plays a very important role here because many people are still not aware about it. So any patient, if you want to advise something, I think counseling will be very important. And I think for that purpose, we have to create more and more awareness. Before creating it for the patients, I think it is among our fraternity, the awareness need to be created. So thank you all for joining. And I welcome all of you once again for this workshop. And now I hand over the program to Dr. Ragini Agrawal for the preamble of the previous day. Dr. Ragini?
Yes. Thank you, Dr. Sheila.
Yeah.
So, very good evening to one and all. This is the second day of the most awaited course of the aesthetic, functional and regenerative gynecology. What we learned yesterday, I will just speak in a few lines. Number one, that this particular specialty started as cosmetic gynecology. Yes, we all have started it as a cosmetic gynecology. Even few people who still follow it as cosmetic gynecology, but you all are who are attending this course is very much agree with me. Urinary incontinence, vaginal laxity, menopausal changes, they are not the part of the beautification. When we talk about the cosmetic it means beautification, pleasing to the eyes. No, we are doctors. We are working for women health, for their quality of life. Aesthetic plays a small role. Medicine is a dynamic process. It increases every day. If we talked about the cosmetic gynecology, when we are ignorant, we are not able to understand properly what this specialty means. At that time, we called it cosmetic gynecology. But as we are moving forward, we understood that we are taking care of the women's diseases, his problems. Maybe it is not so pathological, it is not going to take the life, but they affect their day-to-day life, the quality of life. We at the center, maybe we are the part of the Foxy, we are the part of the ICOG. We try join the hand all over India and try to bring another Indian association, rather I can say Indian Society of Aesthetic and Regenerative Gynecology. And our motto is that our all 38,000 members of the Foxy understand what this subspecialty comes to here. We are not here to earn money from you, 5 lakh and 10 lakh rupees. We are here to educate you, sensitize you, and you can start your own practice because you are qualified obs-gynae professionals. We learned about the basics yesterday, physics from Narendra Malhotra sir, without understanding the basics and physics. It is not possible. And what has changed, that is the energy-based devices, which has given its a new lease. And we came to know what is energy-based devices. They are mostly follow either the electromagnetic rays or the ultrasound waves. And when we talk about the electromagnetic waves, we have lasers, a different kind of the lasers, and the radio frequency, which is again monopolar, bipolar, or now micro needling, and many more has come. Then moving forward, we have gone from the physics, understanding the wavelengths, understanding what is the power, how to use these energy-based devices. And am I not audible? Am I not audible, Sheila?
Yes, ma'am. You are very much.
Okay, somebody has written there is no bias, so I thought.
No. It is okay, ma'am.
From energy-based devices, after learning, we have gone in a detail to learn what is the lasers by Dr. Tanuja Uchil. The three type of laser are there. One is a carbon dioxide laser, another is a erbium YAG laser, and third is a diode laser in the market. They have a different wavelength and their effect is different. Then for laser, we need a chromophore, which may be water, maybe melanin, maybe hemoglobin. And for the RF energy, we don't require any chromophore. RF energy directly heat the water and causes changes. Like if we talk about what does it do, it causes the photostimulation, and from photostimulation to collagen denaturation to collagen new
Let me
formation.
start with pre-test Ragini because all of them will be waiting.
First, we have to do the pre-test or the short.
Madam, still time is there for pre-test. You can continue,
Okay.
ma'am.
So this is the what we have done yesterday, and from here we will start the pre-test for the today, and after the pre-test, the deliberation will start. Okay.
Gauri, start the timing and put the pre-test link in the chat box, please. Gauri,
Yes, ma'am.
put the timer and put the link
Yeah,
in the chat box.
Yeah, I'm putting.
Dr. Apurva Datta, sir. Hello, Dr. Apurva. Hello, Sheila ma'am. Yes. She just introduced the coordinator and Apurva Datta will take over the academic section.
So I would like the coordinators to take over from here, Dr. Suman Sinha and Dr. Apurva Datta. Dr. Suman Sinha is the chairperson of the vaginal surgery committee, and Dr. He is for the STD and the sexual health. And I think they are here with us since yesterday. So I would like the coordinators to take over from here and introduce the chairpersons for the first session.
Hello.
Dr. Apurva Datta?
Yeah. So for the first session, we have four eminent chairperson. The first, I would really give me pleasure to introduce my dear friends from Goa, Dr. Vikram Dukle. Vikram is a very dynamic, and recently he has a wonderful, a center to the cosmetic gynae, dedicated to the cosmetic gynae. So thank you so much, Vikram, for coming here and for giving your time. Thank you. Thank you so much. So our next chairperson is Dr. Amrita Jaipuriyar, madam. Madam again doesn't need any introduction. A very dear senior of mine, very humble, always smiling. Ma'am is the past secretary of the Gorakhpur Obesity Society and the past president of the Gorakhpur Obesity Society. So thank you so much, ma'am, for coming and for giving your time. Welcome, ma'am. Again, the next chairperson is Dr. Archana Verma, ma'am. I'm sure we doesn't need any introduction of Archana, ma'am. Ma'am is ever smiling, ma'am. आपके हंसी के हम सब दीवाने हैं. Ma'am is the past vice president of the Foxy for 2021. Ma'am is the past chairperson of the PSC committee. A lot of conference he was organizing, and thank you so much, ma'am, for coming and for giving us the time. Our next chairperson is very dear, very own Dr. Vinita Singh, ma'am, from Patna. Ma'am is the past president of the Patna Obesity Society. Ma'am is the past chairperson of the YTP committee, and ma'am is the ICOG Foxy Governing Council member too. So thank you so much, ma'am, for coming and for giving you the time. So I would like to invite my dear friend, Dr. Vikram, to introduce our first speaker, Dr. Natasha. Over to you, Vikram.
Good evening, everyone. Thank you at the outset, Dr. Apurva, for having me here. Our first speaker is Dr. Natasha Vijayendran. She's an MBBS MD, a fellow hair restoration specialist, and a certified injector. She's a dermatologist, a hair transplant surgeon, aesthetic injector, a laser specialist, a holistic dermatology she practices. And she's practicing at AA Derma Science Gurgaon, founder and head of Violet Aesthetics, Hiranandani Estate, Mumbai. I welcome Dr. Natasha for this talk.
Thank you for such a warm welcome, Vikram. Good evening, ma'ams. Good evening, everyone. Thank you for having me over here. I'll just share my screen. Is this visible?
Yes, ma'am.
Oh, okay. So,
yes, it is.
Good evening, everyone. So today we will be discussing vulval rejuvenation with respect to how can injectables like Botox and fillers and even rejuvenation treatments like chemical peel, how will they make a difference to the vulval skin? Now, the vulva is very important because it is the one intimate area that is exposed to the environment, and hence the signs of changes and the signs of aging, menopause can be seen in this area at the beginning of the aging process. So we will be discussing botulinum toxin first. Now, botulinum toxin is available in the market. It has been used as approved indications for gynecological issues. So let's discuss what it is being used for. So botulinum is a neurotoxin produced by Clostridium botulinum. It is a type A, which is approved for use in vaginismus. Now, how does it work? It prevents acetylcholine release, and hence the neuromuscular transmission is interrupted, causing temporary muscle weakness. Now, it's important to understand it's temporary. It lasts for about 3 to 4 months, and then another session is needed for the same concern again. Now, other pathways that Botox does affect is the autonomic ganglia, the postganglionic parasympathetic nerve endings, and the postganglionic sympathetic nerve endings. Now, this is important when we're giving Botox into the vulva or the vagina, as the nerve supply is very rich in this area. And at times, sometimes due to exacerbation of the Botox and its absorption into the other muscular structures or the other nerve endings which are present in the vulva, can cause some changes in paraesthesia, and it can also lead to some sort of inconsistencies, which we will get to when we read the side effects. Now, post-injection, the onset of the effects are seen within 3 to 7 days, and it typically lasts for 3 to 4 months, depending on the brand of botulinum toxin that we are using. Now, when we're using botulinum toxin, it is either available in a 50 units vial or a 100 units vial. It would be better to use a 100 units vial, as the quantity that we need to use is 150 to 400 units when we are treating vaginismus. It is diluted with normal saline without any preservative. 0.9% NS is used, and 2.5 ml is used for every 100 units. Now, when we're injecting, as you can see in the diagram that I have attached here with, 150 to 400 units is injected in total. So that's about 45 to 50 units per site. It's injected into the puborectalis muscle in 3 points on each side of the vagina. Now, mild sedation can be given. However, care is taken because we're going to ask the patient to contract their muscles in that area to visualize the exact location of the muscle and where it is more severe, and hence only mild sedation is needed and not total sedation. Now, here is a video on how to prepare Botox. I'm sorry. So this is how botulinum is available. This is normal saline. We take a 2.5 ml syringe, wear sterile gloves, draw out the saline into your syringe. Now, Botox is free-dried, so we don't need to push the NS into it and just whirl the vial around. Carefully, we can measure the units in an insulin or tuberculin syringe, and we are set and ready to go. So an insulin syringe is about 40 units. That tells us how much we need to inject into per point. Points to keep in mind while reconstituting Botox: 2.5 ml NS for 100 units Botox. Use a sterile glove. It's freeze dried, so when we put the needle into the Botox, we don't need to push it. We just let it absorbs through the vacuum that is created. Now, the indications, of course, severe and mild refractory cases of vaginismus, but the contraindications would be pregnancy, infections, any neuromuscular transmission diseases, coagulopathy or anticoagulability diseases, and hypersensitivity to albumin or botulinum toxin. So a test dose can also be given in the forearm to see if there is any hypersensitivity to this toxin. Side effects: fecal and urinary incontinence, which can last for again 3 to 4 months. So pelvic strengthening exercises is very important. And some patients do experience an unusual pressure pain in the vagina. That is because the superficial nerve endings might have got affected. And this is separate from the vaginismus pain. Coming to hyaluronic acid fillers, this has been taking a huge role, especially in today's vaginal rejuvenation, because people are worried about vaginal laxity, fine lines and wrinkles that come in that area, vulval atrophy that takes place, and hence this is where hyaluronic acid fillers enter into cosmetic gynecology. So hyaluronic acid is a natural present polymer belonging to the group of heteropolysaccharides, and it is found predominantly naturally occurring in the extracellular matrix and pericellular matrix. Now, the high molecular weight of hyaluronic acid is 10 DA, and the total amount of HA in the body is 15 grams for about a 70 kg adult. Now, 50% of this HA resides in the skin. Apart from the conjunctiva, your joints, most of the HA is present in the skin, and hence the skin is the first place to show changes of aging or dryness or, any type of irritation that might be present in vulval skin will show in terms of HA and dryness as the first sign. So most perimenopausal women come to us with a dry vulva, or if there is any chronic disorder like LSC or itching or pruritus or any type of irritation in that area, that chronic itch cycle causes an extra depletion in the HA in the skin in that area, and that is when these concerns trigger. Let's go to the next slide. So if you see, as young skin, the collagen is thicker, hyaluronic acid content is higher, and hence it makes the skin look plump, smooth, and supple, and also adds to the hydration of that skin. So when we talk about the aging process, as we see, there is a breakdown of collagen that gives skin to become lax and fine lines and wrinkles to come in, and also the HA levels decrease that causes many skin structural changes. So what are the skin changes that we see with time in the vulva? Loss of skin moisture, that's dry skin, dull skin, loss of skin structure or volume, the skin becomes loose, wrinkles are seen, textural changes are seen, and the labia becomes hypertrophic. And that is where hyaluronic acid fillers come into play. What does hyaluronic acid fillers do in this area? It's going to rehydrate the skin, it's going to plump the skin, it's going to improve the skin texture, and it's going to replace the volume that has been depleted due to the aging process. So when we look at labia majora hypertrophy, there are three severities. Stage 1 and stage 2 can be treated very well with hyaluronic acid fillers. And the typical labial puff that is needed, that is basically we are volumizing the labia majora to conceal the labia minora in order to give a proportionate appearance. So we're trying to reduce the dryness, we're improving the sensitivity in that area, we're strengthening the muscles and restoring the tone and elasticity. And this has a big impact on the quality of life for the patient, as simple things like sitting, exercising, wearing tighter trousers become more comfortable, and it is a psychological benefit to them also, and a visual benefit to the patient and her partner. So how do you choose the right patient? Check the duration. How long has the dryness been there? Are there any other comorbidities in that area? What is the activity of the concern? Is it affecting their quality of life? Are they continuously itching that area in a very uneasy manner in day-to-day activity? Are they having sexual issues? Those are pointers that we must keep in mind when we are counseling and taking history of the patient. A pap smear is important. And last but not least, when it comes to cosmetic gynecology or vaginal rejuvenation, expectation and promise discussion is very important, because giving false expectations or seeing even what the expectation of the patient is very important, and correcting these wrong expectations is extremely important as well. What are the patients that you would exclude and not do fillers for? If there is any type of active vaginal infection, it could be a bacterial, fungal, or viral infection, urinary infections and pregnancy, any malignant pathologies of active herpes viral infection, allergies or previous reaction to fillers, chronic corticosteroid therapy will thin out the skin and cause atrophy, which might lead to more scarring, and hence fillers are avoided in these cases. And of course, as I mentioned before, unrealistic expectations. Coming to what are the types of hyaluronic acid that is available, we have injectable hyaluronic acid, we have oral hyaluronic acid, and nowadays we even have topical formulations of hyaluronic acid. So in a lot of our perimenopausal patients, even an oral formulation of a moisturizing ingredient, a brand name like Tablet Skin Fe works very well in hydrating the skin of the vulva, and it helps in preventing that itch or that uneasiness, and it slows down the aging in that area. Topical formulations also work well. So many lotions and creams that have hyaluronic acid, ceramides, peptides help in strengthening the skin in that area. And of course, injectable methods are also available. So when we look at injectable hyaluronic acid, there are three types. There is a high molecule, which is 24 milligram per ml, and a mid molecule, which is 19 to 17.5. We use the mid or the moderate G prime range much more in the vulva. And skin moisturizers like Bolite or skin boosters do wonders for the vulval skin. They are known as biostimulators, they're known as injectable moisturizers, and it instantly regenerates the skin to produce more collagen and elastin, and improves the hydration of the vulval skin. So other than injectable hyaluronic acid injections in terms of fillers, today we have something which is known as skin moisturizers. Profilo, Volite, skin boosters, they work exceptionally well to hydrate the vulval skin. So here in this picture, there are different types. As we spoke, thick to thin or higher G prime to lower G prime. We in the vulval area use lower G prime. So anything between 19 to 17.5 is used in this area. You can use Juvederm, Volite, Volbella, Volift in this area, and even Voluma. Volux is too heavy of a G prime to use in this area. Now, the regional anatomy is extremely important while injecting because we do not want to do any intra-arterial injection that can lead to necrosis. So when we're injecting the perivulval skin, we are injecting the dermal area or the subcutaneous areas. As you can see in this picture, the white arrows are the layers of the smooth muscle that is immediately below the skin. And then the red arrow is the fibrous tunic, which is also known as the elastic stack, which is the adipose fat body, and we do not inject into this area. The blood supply, knowing the blood supply of the vulva is very important. So we have the anterior labial arteries, the branches of the external pudendal arteries, and the posterior labial arteries. And hence an adequate knowledge of their localization is fundamental to avoid any intraluminal infiltration with potential necrosis chance. So nowadays, what you can do is you get a handhold venous meter. So you can just place it on the skin. LED light is put right through and you can see the superficial branches, and that helps while injecting in this area. Now, what are the complications that we can see? Reactivation of any infection, whether it is viral like herpes simplex or a bacterial infection. Bruising is seen, so we can give topical arnica or an oral formulation of arnica. Swelling, erythema is very common and a normal side effect. It usually lasts for about 3 to 5 days. Intraluminal injection can lead to necrosis, and we need to know how to treat that side effect as well. And here we use an injection known as hyaluronidase. It is injected into the area of occlusion. Wherever you see there is bruising or pallor or any kind of erythema or signs of necrosis, then it is injected immediately into that area. If there is any bumps, that could mean that it is a superficial infection, superficial injection. So massaging that area usually helps in dissolving this bump. Coming to the procedure, what do you do in the procedure? An anesthetic cream is applied to that area. After about 45 minutes, a 27 to 32 gauge needle or cannula can be used. We inject the appropriate areas and massage it. Topical antibiotic and antifungal is very important, along with oral antibiotics for 5 days. Ziffy or amoxiclav can be given. The results are usually seen optimally in 21 days, and the quantity can be anywhere between 1 ml to 4 ml. 2 ml is usually an average that we use in this area. So please don't click any pictures, but here these are pictures of before and after of moderate hypertrophy of the labia majora. Here we injected 19 milligrams hyaluronic acid. So we used Juvederm Volift, and these are the changes that were seen after about 1 month's time. The second treatment was done at 6 months, but the same quantity was not used. We used only 1 ml per part. These are a few more pictures. Okay. Coming to chemical peels. Now, vulval aging, of course, we see in terms has a great psychological impact because of melanin, which is the primarily what increases in the skin with aging. There's atrophy of the skin, there's dehydration, there's wrinkling of the skin. And because of all these changes, there's an increase in melanin in the skin as well. So various changes that the woman would have experienced during her aging, post-inflammatory hyperpigmentation, acanthosis, repeated friction in that area can all cause cosmetic concerns that would need vulval bleaching. So we have different types of pigmentation. We have physiological hyperpigmentation as seen here. This is another picture of physiological hyperpigmentation. You could have post-inflammatory hyperpigmentation or hypo. This is post-LSC. You can have acanthosis nigricans, which is due to your metabolic syndrome. And you can also have a frictional melanosis. So all these types of pigmentation can be treated with peels, but understanding a realistic expectation, ruling out any underlying trigger to the pigmentation is important. When it comes to chemical peels, alpha hydroxy acid is what is used because that helps with chemical exfoliation and also reducing the melanin content in the skin. As a standard, glycolic acid peels can be used starting from anywhere from 20 to 35 to 50%. Lactic acid and kojic acid is milder, and you have various combinations with glycolic with kojic, glycolic with lactic acid that can be used in the vulval area. Again, patient selection is important, taking in history and understanding the duration of how long the treatment has or the concern has been there. Ruling out metabolic pigmentation and any other pathology is extremely important. So this is again a broad list of the peels that can be used. Glycolic, lactic, and kojic is the most common. And TCA peels, it's better to avoid in this area until and unless it's acanthosis nigricans. But care must be taken post peels that they're using a topical steroid to avoid any irritation or inflammation in that area. So here are a few pictures of vulval bleaching. We have not only used peels here, we have used lasers as well. But this is the amount of vulval bleaching that can be achieved. Thank you. Have a lovely evening. If you all have any questions, you all can post it down in the comment section as well.
Thank you, Dr. Natasha. That was quite elaborate and quite, it covered everything. Very happy to have you. Even most of the doubts were cleared, I think so, regarding the topic, and you did it really well. Thank you.
Thank you so much.
Any questions from the audience?
Yes, Dr. Natasha. I'm Amrita Jaipuriar. I thank Dr. Ragni for giving me the opportunity, and it was great hearing you. And the best point is that, like in this era of cosmetic gynecology and everybody running after cosmetics, you said a very right word, that the patient should be screened properly. Before doing any vulval procedure or anything else, we should do a pap smear. And we should check that patient is not suffering from any pathology, any CA or something like that. And then we should jump on the cosmetic part of the patient. We should rule out every medical problem, especially the cancers, and then go ahead with the cosmetic procedures. That was very right of you. And yes, with medical science, with the advancement, everybody is having very high expectations from us. And it is true for the cosmetics also. And people think that they'll be as normal as they were in their younger days. So even that should be counseled properly, and we should take care that patient does not expect too much from us. So it was nice hearing you. It was very elaborate and a wonderful talk. Thank you so much.
Can I ask one question, Dr. Natasha and Dr.
Yes,
Varsha
ma'am.
Basti from Nasik?
Yes, ma'am.
You have mentioned 30 to 50% of glycolic acid to use. Is it not harmful for the skin? What do you say?
No, ma'am. So glycolic acid.
3%, 5%.
No. So glycolic acid.
Maximum 6% for the peel.
So glycolic acid up to 15% is available OTC. So it's not a medical grade up to 15%. It's available in creams and lotions that you all can give your patients to use at home even once or twice a week. However, when it's coming for the vulval skin, we as dermatologists use minimum 35%, and after repeated sessions, we go up to 50 as well. It is
The same you will advise for acanthosis nigricans also?
Yes, definitely. We use about 50% in acanthosis. We even use deeper peels like TCA for acanthosis. But care is very important. So during the procedure, care, post-procedure counseling and telling the patient.
Hydration and all.
Yes, is extremely important.
Thank you.
And proper priming of this.
There's a question from the audience. Which are the most common peels that you use for hyperpigmentation in your day-to-day practice?
So I like using combination peels, glycolic with kojic, glycolic with lactic, yellow. Someone has asked, Sangeeta ma'am has asked, yellow peel preferred. I do not prefer the yellow peel, as there have been a lot of side effects with it, and I prefer to stick to peels that provide less amount of exfoliation, less irritation, because we are treating the intimate area here. We're not treating the hands or the legs or the face per se, which is even more manageable in terms of any complication. So Glyco-K, Glyco-H, retinol-based peels work excellently well.
And I just wanted to clear this doubt also. Many of my friends say that you have to do a laser hair reduction before you start with the peel. Is that true?
No, that's definitely not true. But definitely doing a laser reduction is going to reduce the melanin content because your hair follicle is melanin based. So one is pigmentation is going to reduce, texture is going to become better as well because it's going to become smoother. Also, what happens is the laser targets pigmentation as well. The bandwidth and the wavelength of hair removal targets pigmentation. But there's no head fast rule that you need to remove the hair before you do a peel. Nothing like that. We are treating vulval skin. If you're doing the entire vaginal rejuvenation, then I would suggest you can shave before you do your peel, but wait for at least 2-3 days gap between shaving and doing your peel.
Thank you. Thank you so
Thank
much.
you. And
So,
I
very good
just want
evening.
to,
Good
yeah.
evening, Vinita ma'am. Yes.
Yeah, good evening. So I'm here. Sorry for joining a bit late. So it was really a wonderful talk by Natasha, and I'm really fascinated to know about so many things regarding Botox, fillers, and peels. So it was a wonderful talk. So let me see how this Gunjan Gupta, she is going to, tell us about the next. She is the next speaker on PRP.
Definitely.
I just thank you so much, and I just want to ask the delegates if they have any questions. Please put it in the chat box, and the speakers can you just answer their queries in the chat box. Thank you. Thank you so much.
So I think the next speaker is Anshu Dhar, if I'm not wrong.
Yes, ma'am. Yes, ma'am.
Yeah. So she is going to speak on PRP, which is a very upcoming. Every time we are hearing about PRP, so she is a very senior IVF consultant in Gunjan IVF World, and she has done her MD FNB in reproductive medicine, advanced diploma in reproductive medicine from Kiel, Germany, and she has done advanced diploma in cosmetic gynecology from Germany too, specialization in gynae IVF endoscopic surgery and fertility, and speaker at various national conferences. So it's so nice to hear about you, Anshu. And she has published papers in national and international journals and authored chapters in renowned reproductive medicine textbooks. So let us hear from Anshu Dhar about PRP.
Good evening, ma'am. Just a second, I'll be sharing my screen. Is my screen visible?
Yes, ma'am.
Yes.
Hi, everyone. Good evening. I'm Dr. Anshu, and I will be giving you a brief overview of platelet-rich plasma. This talk was supposed to be taken by Dr. Gunjan. Due to some personal reasons, she won't be available. So here I am, and let's take this forward. So let's just recapitulate in the beginning what exactly are the platelets. My presentation, okay. See, platelets, as we all know, they are just fragments of cells called megakaryocytes from the bone marrow, which are very small in size, just 2 microns. They not only play a very important role in wound healing wherever there is an injury, but they also are a powerful storehouse of so many bioactive proteins and growth factors. These days, wherever we go, whether it is in the field of orthopedics, it is in the field of cosmetology, it is in the field of gynecology, reproductive medicine, regenerative medicine, and whatnot, all we are hearing about these days is PRP. What exactly is this PRP? See, PRP is basically a concentrate of platelets, and there is a working definition of PRP, which many of us tend to forget. We just believe that it is a concentrated form of platelets, and that is why there is such a degree of discrepancy in the way that PRP is manufactured. It is made by all of us, and it is being used rampantly. But we have to remember that unless the concentration of the platelets is 10 lakh per microliter, we cannot label it as PRP. This definition has been arrived by various studies which have shown that any kind of regenerative or reparative effect of PRP is seen only at a concentration which is above this level. What is all this hype about PRP? Why is everybody talking about PRP? See, PRP is basically a cocktail of so many growth factors. It contains platelet-derived growth factor, epidermal growth factor, your transforming growth factor, alpha beta, insulin-like growth factors, fibroblast growth factors, and whatnot. And all these factors come together. They act on multiple receptors and initiate a downstream cascade of signals leading to mitogenesis, angiogenesis, and other than that, tissue healing, repair, just hold on collagen synthesis, protein synthesis, and chemotaxis of all the cells which come together at any particular site where this PRP is injected and cause regeneration and repair of all the tissues. So this is a very busy slide, just showing all the growth factors which are present in the platelets, as we've already discussed. The basic function of all these growth factors which are present in the platelets is simply to attract the other cells to come to the site wherever the PRPs are injected and initiate all the changes which together increase the blood supply to that area, bring more oxygen to that area, take away the waste products from that area. In addition, initiate the work of fibroblasts, lay down collagen, and in turn, reverse the changes which aging may result in. Now, there are various terms which all of us should be familiar with when we are talking about PRP. There are various types of PRP. One thing is pure platelet-rich plasma, and the other one is platelet-rich plasma along with leukocytes. These are two subsets which are commonly used in the field of cosmetology. Other than that, there are some other products also, which are leukocyte and PRF, which is platelet-rich fibrin and pure platelet-rich fibrin. These fibrin products are not essentially used in the field of cosmetology or aesthetics. They are more commonly used in regenerative medicine, and they are used more commonly in the fields where we are focusing more on your wound healing, your repair of tissues, acceptance of skin graft, and all those places. In the field of cosmetology, we should focus ourselves primarily on pure platelet-rich plasma. There is some use for leukocyte-rich leukocyte with platelet-rich plasma also, but that is in the cases where there is a little bit of scarring, where we are using PRP to correct the scarring. Because wherever there will be leukocytes, there will be inflammation and there will be a laying down of collagen. Other than that, where we are simply using your PRP for rejuvenation of the tissues, we prefer using platelet-rich plasma, which is pure, to avoid any kind of inflammation in that particular area or to reduce the inflammation which can happen once we inject the PRP. Now, important question which arises is, how do we prepare PRP? The problem with PRP is that there are n number of ways in which people are preparing PRP. There is no one particular standard way. If there are 7 clinics using PRP and you ask them how you are using the PRP, how you're manufacturing or making your PRP, what answer you will get will be completely different in each of the cases because there is no one particular standard protocol. But the most important thing is all the protocols follow one single generic sequence, which primarily consists of collection of your venous blood. Then we centrifuge that blood. That is, we do differential centrifugation, the aim of which is to cause the RBCs to separate from our plasma mixed with platelets. And then once the plasma rich in platelets has been separated from the RBCs, then we subject it further to another set of centrifugation to concentrate the platelet pellet. And then there is activation of the sample by addition of platelet agonist, which is something which is again very controversial. So basically, there are two primary methods which are used for the preparation of PRP. One is the PRP method and the other is the Buffy-Coat method. So what do we do in the PRP method is we take the venous sample of whole blood in acid citrate dextrose tubes. We have to collect the blood in the ACD tubes because if we do not use an anticoagulant along with it, it will cause activation of the coagulation cascade and cause the platelets to get trapped in a fibrin mesh, and then we will not be able to concentrate or get those platelets. Also, it may lead to premature activation of platelets. So once we have collected the blood, then it is subjected to a soft spin. That is, we centrifuge it at a lower rate. Now, again, this soft spin is being done by various centers at various rates, but what is usually recommended is using a centrifugal force between 100 to 300 G for a duration of 5 to 10 minutes. Once that happens, once we have subjected the whole blood to soft spin, the blood gets broken down into its three components. The red blood cells tend to settle down at the bottom. Then there is this layer of cloudy buffy coat. This buffy coat contains platelets along with your WBCs or leukocytes. And then there is this plasma which contains platelets, which is rich in platelets. Then what do? We take, again, as we talked previously about the two types of PRP. One was pure PRP, in which there is very less concentration of leukocytes, which is the kind of PRP which is most commonly used. And the second type of PRP, which is leukocyte rich. How do we make these two types of PRP? In the first preparation, if we are thinking about making a pure PRP, we take most of this plasma along with the little bit of buffy coat, because we know that this buffy coat is also containing white blood cells. And then we subject it to centrifugation. On the other hand, if we want to make LPRP, that is leukocyte and PRP, then what do? Is we take whole of this buffy coat and subject it to second centrifugation, which is the hard spin. That is spin at a higher rate. So here we are using a centrifugal force in the second spin of somewhere between 400 to 700 G for a duration between 10 to 17 minutes. And once that is done, what we get is a separate pellet of platelets which settles down at the bottom. And here we get the, can you see my screen? Is my screen visible?
Yes, we can see. Yeah, Anshu.
Yes.
We are seeing.
Okay, fine.
Visible, madam.
Okay, thank you. So the platelets have a tendency to settle down at the bottom and form a pellet. Above that, we get a coat of platelet-rich plasma and another coat of platelet-poor plasma. So what do? Is we separate, we take out these upper 2/3 and we discard it. This is platelet-poor plasma. And then the remaining 1/3 in the tube is mixed with the platelet pellet. The platelets are suspended by keeping them for 5 to 10 minutes so that we get a homogeneous mixture, so that platelets get evenly distributed in the small volume of plasma that remains. And then we get this PRP. So this is, somebody is asking, can you tell the parameters for hard spin? I'll repeat. The parameters for hard spin are using a force of 400 to 700 G for 10 to 17 minutes. It depends upon what kind of tubes you are using, what is the kind of centrifuge that you are using, and what your lab parameters are like. So that we'll be discussing subsequently. So this is basically how we prepare the PRP by the PRP method. As I have already told, initially collection of blood in the tubes, then the first spin, after which the blood gets separated into its three layers: plasma, the buffy coat, the RBCs. Remove the plasma along with a bit of buffy coat, take it into tubes which are conical, and then subject these conical tubes further to second hard spin. We get this small pellet, which is then resuspended in the lower third of plasma to get PRP. The second method, which is not very commonly used, is the buffy coat method. In the buffy coat method, we directly subject the whole blood to a high-speed spin. What is the problem with Buffy-Coat method is it gives us, again, that also, there is another question. I'll be taking the questions in the end. I'm sorry. That causes a bit of interruption. Okay. So once we subject the whole blood to a high speed of centrifugation in the Buffy-Coat method, the blood gets separated into its three constituents. One is the plasma, the second is this cloudy layer of Buffy-Coat, and the third is the RBCs, which get separated. Here, what happens is all the platelets get concentrated in this very thin layer of Buffy-Coat. And this plasma is platelet poor. So to extract the platelets, we have to separate this Buffy-Coat, which becomes very difficult because it is very less in volume. So this is a method which is not very commonly used. Other than these methods, which are used most commonly, there are many other commercially available PRP kits, some of which are FDA approved, claim to be FDA approved. However, we have to understand that all these kits which are available and which claim to be FDA approved, they do not, the FDA approval is for their safety. It is not for the efficacy of the platelet or the platelet-rich plasma concentration that we get. It is not a reflector of the efficacy of those kits. It's just the safety part. And all these different commercially available PRP kits differ in the concentration of platelets that they give, the recommendations of the manufacturers for the spins, and that's why there is a lot of controversy regarding what process should be actually used for preparation of PRP, and it varies from every lab, as I've already told. Now, the next thing is what is activation of platelets? Now, platelets contain granules. All the growth factors which are contained inside the platelets are contained in small granules. And unless those granules come and fuse with the membrane of the platelets, there will not be release of these growth factors. So the process by which all these granules which are present in the platelets come and fuse with the membrane of the platelets and release all the constituents outside is the activation of platelets. Now, these sometimes it is believed that PRP always needs activation, but does it? Should PRP always be activated? Again, it is a controversial thing. There is no consensus on whether or not platelets must be previously activated before their activation, before their application, and with which agonist. See, when we are injecting your PRP into the soft tissues already contain type 1 collagen. And it is believed that PRP does not require any kind of activation when it is to be used in soft tissues. On the other hand, if it is getting used in tissues like bones, etc., then sometimes we use platelet activators like thrombin or calcium. Now, what are the various factors which influence the PRP yield? First thing is draw of blood. We have to make sure that when we are taking the venous blood, it is to be taken with a broad gauge needle. At least 22 gauge needle should be used. If a very thin needle is used to draw the blood, what will happen is because of the mechanical pressure which is getting exerted on the platelets, they will get activated in the very beginning, and that is something which we do not want. The second thing is use of anticoagulants. Now, various anticoagulants, we know there are so many different anticoagulants. We have heparin, we have acid citrate, dextrose, all these anticoagulants are present, EDTA. But then, according to the multiple studies that have been done, there is a conclusion that the best anticoagulant which should be used when we are making PRP is acid citrate dextrose. Because of its low pH, it prevents the premature activation of the platelets, and at the same time, it maintains membrane integrity of the platelets. Now, somebody was asking about what is the concentration of anticoagulant or ACD which is to be used when we are making our own PRP. See, when we are using anticoagulants, we should put 10% of the anticoagulant in the mixture. So how do we do it? Suppose we have taken 5 ml of blood. I'm just giving an example. 5 ml would be very less. If we are taking 5 ml of blood, then we have to add 0.5 ml of ACD. This is the proportion, 10%. 10% of the solution should be your ACD. The third thing is temperature. The best temperature is 21 to 24 degrees. Then is the speed of centrifugation. I have already told. Okay, I'm getting a message that my time is up. I'll try to speed up the things. So centrifugation. I've already told the speed which is required for centrifugation in this case. Just a second. And precautions for PRP preparation, we have to make sure that when we make the PRP, we mix the anticoagulant and the blood nicely. And then we have to make sure if we are not getting adequate concentration of platelets, then we have to change the parameters like the centrifugal force that is getting used and the time for which we are subjecting the solution to centrifugation. And once we get the platelet pellet, we have to make sure that we separate it quickly. We separate it from the platelet poor plasma, otherwise all the platelet pellet will get diffused slowly back into the platelet poor plasma. What are the contraindications for the use of PRP? If a person is having platelet dysfunction syndrome, very obvious. If there is critical thrombocytopenia, if the patient is not hemodynamically stable, if there is any kind of infection in the body, and obviously, as Dr. Natasha very rightly said, any cosmetic procedure should not be done in a person who has unrealistic expectations. See, it's just a medical procedure. It is not magic. It cannot magically reverse the age. Okay. And then there are certain relative contraindications if the person is heavy smoker, using drugs or alcohols, chronic liver pathology, any kind of systemic disorders, any cancer, especially if there is a history of blood cancer, low hemoglobin, use of steroids for a long time, regular use of NSAIDs, or the person on anticoagulant therapy. In the preliminary workup, before we go ahead and do PRP for anybody, we have to check the baseline hemoglobin in the platelet count, do the viral markers. And again, as Dr. Natasha very rightly said, we have to make sure that we do a local examination of the part where we are going to inject the PRP. And we have to take an LBC or a pap smear as already told. And if the patient is having any history of herpes, so that we do not precipitate any kind of herpes again, by our procedure, we have to give an antiviral prophylaxis in the form of acyclovir, which is 400 mg BD, or valcyclovir 500 mg once a day for 5 to 7 days. And then coming to the uses of PRP, see, the most important use of PRP is in rejuvenation of the tissues in the field of gynecology, cosmetic gynecology. What happens with aging is there is a flattening of dermal epidermal junction. There is an alteration in the dermal extracellular matrix proteins. There is an atrophy of the dermis. There is a decrease in the hyaluronic acid polymers. There is a degeneration of the connective tissue. All these changes happen with aging. So these changes get, to some extent, reversed or arrested for some time once we inject PRP in the tissues, as PRP, as I've already told, contains so many growth factors and causes all the fibroblasts and remodeling of extracellular matrix and production of collagen in the area. So essentially, the work is same in all the indications, whether we are using it for skin rejuvenation, whether we are using it to improve the tone of labia majora minora, a procedure which is commonly known as vampire wing lift, whether we are using it for scarring. One important thing which is rarely ever discussed and is commonly coming up is the use of platelet poor plasma as biofiller in aesthetics. Once I have told already how do we prepare the PRP, the topmost layer is the platelet poor plasma. Now this platelet poor plasma usually is discarded, but recently a new use of this platelet poor plasma has come up as a biofiller. What is done is that these platelet poor plasma, the proteins which are contained in the platelet poor plasma are subjected to coagulation by means of heat, and they form a gel-like substance, and this gel-like substance can be used as a biofiller. There are certain studies which have shown that this biofiller can stay in its place for as long as 1 month. and even 3 to 4 months, but the majority of effect starts slowly fading away after 1 month. In vulvar cancer surgeries, people have been using PRP and platelet gels, and in breast reconstruction with autologous fat graft. Here, what does PRP do in breast reconstruction or wherever we are doing autologous fat graft? PRP tries to maintain the blood supply to that area by promoting angiogenesis. Initially, when we put the fat graft inside there, it may undergo ischemia, leading to rejection of the graft. But when it is done with PRP, it is seen that the angiogenesis to the fat graft is maintained, and the chances of the take-up of graft and its staying are more. In female sexual dysfunction, PRP is being used in the form of O shots, which are specifically injected. See, this is a registered trademark. This is not a term which is commonly used. O shot is the registered trademark of a company, but what they are doing is they are injecting PRP into the area which is believed to have the maximum concentration of the nerves around the clitoris and the anterior wall of the vagina. And it has been seen that it improves the vascularity, the elasticity of the tissue, and it helps more in sexual arousal. And because of the regeneration of the nerves to that area, it makes sex more pleasurable. And then vaginal rejuvenation, again, the role of PRP, it increases vaginal vascularity. It makes the skin become thicker and firmer. Now, who's the ideal candidate for PRP? As we have already told, that unrealistic expectations are not to be entertained. We have to clarify to the patient that it is not going to miraculously change something. And especially if the patient is very old, the PRP does not work well because the number of growth factor receptors keep on decreasing with age. And at the same time, the capacity of the fibroblasts, the old fibroblasts, to produce collagen also decreases. So the younger the person, the better will be the results of PRP. So how frequently should the PRP be injected? The PRP should be injected at least monthly, and sessions, about 4 to 6 sessions are required. After PRP therapy, for 3 days, the patient is asked to avoid any kind of sexual activity, any kind of exposure to steam baths, any exposure to direct sunlight, and obviously to wear cotton undergarments for at least 5 days. Now, as we come to a close of this topic, is PRP actually a panacea? Is it the solution to all our problems as it is getting projected to be? The answer is no. While there are n number of studies saying that PRP is a solution to so many problems in different fields, there is an equally good number of studies which are suggesting that it is not so, and it is not better than even normal cell line. Now, how does this kind of discrepancy exist? This is because of the fact that PRP is, the preparation of PRP is not standardized. People are using different ways of making PRP. There is no way in which people are checking after making PRP whether it contains adequate number of platelets which is required for the solution to be called a PRP. So because of the lack of standardization, these studies are something which cannot be relied upon. So when we are sitting here in this forum and we are discussing PRP, we should not just go and blindly start following it. I think our role when we are sitting here, and so many people, more than 300, we are sitting here and discussing, I think what we should take home is that yes, we will use PRP, but we'll use it in a more standardized manner. And at the same time, we'll try to use it in the context of randomized trials or clinical trials so that we can generate more robust data and we can come to a conclusion of how efficacious PRP actually is. So the take-home message is there is moderate level of evidence which is available for PRP as a treatment modality for skin rejuvenation, for scars, lipofilling, etc. The best candidates are younger patients. Biofillers, PPP that I told, platelet poor plasma can be used as a biofiller, and it is something in which more research should be done because it is a lot less expensive as compared to the actual fillers. The mode of treatment which is preferred is not topical PRP, but intradermal PRP. 3 to 6 sessions at monthly intervals are recommended. And even though it is a very safe procedure, the problems which are mostly faced after PRP are in the form of erythema, redness, some small degree of pain, or some photosensitivity, but nothing else. But the longevity of the results is questionable. So, as we all draw to an end of this topic, the most important thing is, as we are discussing the ways and means to enhance beauty and to reverse aging, we have to remember that age is no barrier. It is just a limitation that we all put on our minds. So stay young, and thank you.
Thank you, Anshu. It was really a very wonderful talk. And really, I do agree with you that there should be some standard protocol for preparing PRP. So
Yes,
actually,
ma'am.
PRP we are using in every, in cosmetic gynae or facial rejuvenation, vaginal rejuvenation, and thin endometrium, and so on. So there should be some standard protocol for preparing this PRP. And I think we are using now, instead of PRP, we have gone to PRF. So I think it's a very good, but definitely, I do agree with you. It doesn't do something, miracle to the face or hair.
Yes,
I mean,
ma'am.
vaginal rejuvenation, thin endometrium, but still we are doing. So there must be, more research should go on, and it should be more, with the standard protocol, I think. So one question, are you preparing this PRP issue of yourself, or some lab technician, they are preparing this,
Ma'am, we are basically an infertility clinic. We are using PRP in thin endometrium for ovarian rejuvenation. We are making our own PRP.
Okay, so for ovarian rejuvenation, are you using PRP or PRF? So fibrin you are using, or PRP you are using?
Ma'am, we are using PRP only.
PRP only. Okay. So thank you very much, Anshu. It was really a very good talk.
Thank you,
Any
ma'am.
question? Any question?
Ma'am, actually, I always ask, please the delegates, put your question in the chat box, and I request to all the speakers, please answer them
answer.
directly in the chat box. So
Okay.
thank you so much,
Yeah.
Dr. Anshan. Thank you so much, Vinita ma'am. So
Yeah.
for the first session, we have the last talk, and I would like to invite Amrita ma'am to please introduce our next speaker, our own Dr. Varsha Vatse ma'am. She will be speaking on the stem cell.
Thank you.
Amrita ma'am, are you there? Okay. Vinita ma'am, can you just please do?
Yeah.
introduce
So
Varsha
I'm
ma'am?
so happy to introduce Varsha. She's a very good friend of mine. And I know her since long. So I know she is a very good, practitioner, practicing as gynecologist in
Nibha ma'am, may I do the honors?
the
I was
last.
muted. The host did not allow to
Yeah,
unmute.
Amrita. Yes, Amrita. Yes.
Yeah, thank you so
Yes.
much, ma'am.
Okay.
It's a wonderful opportunity to introduce Dr. Varsha Baste. She's the Vice President, West Zone. Very, very dynamic, a fashionist, very attractive. And she's a practicing gynecologist and director of her own hospital. And she has been the chairperson, International Exchange Committee, and she has done a lot of work in that. So over to you, Varsha ma'am. Many publications to her credit and most sought after faculty everywhere. Over to you, Varsha ma'am. Hello?
Ma'am, I think Dr. Varsha Baste ma'am log out, maybe network issue.
Oh,
Yeah.
she was there?
Actually, she must have lost her connection. Just
Yeah,
let me check. Yeah.
Please,
Yeah.
can you? I think so. She is there, but please make her co-host.
Yeah. Okay. Gauri, please make the
That was
co-host.
unable to speak. Yeah.
Ma'am is not there, ma'am.
No, she was there. Just wait. Yeah, probably some network issue. Just I am calling you.
I'm just phoning Varsha. She is again logging. Meantime, we have lots of questions regarding PRP. Dr. Anshu, are you there? Dr. Anshu? So when we talk about the PRP,
Yeah, Ragini
the
ma'am,
main thing
I
we
think
should
you are the best
understand, we
person
need
to answer.
no license of any type. Number two, PRP is a autologous component. So you can give that particular patient from you, have to take the blood. Mostly we require for any procedure 5 ml PRP, and that 5 ml PRP is readied from the 50 ml of the blood. This is the general formula for the PRP. And as far as the PRP is concerned, the double spin is always better, and the temperature what we maintain is 25 degrees centigrade. So these are the few questions. And as far as the INSARG website link is concerned, we have no website yet. I'm just typing the contact number here. Please contact on this number and you can get the all details. Or कौन से question है? Which type of the PRP used to facial regeneration? The facial regeneration, when you use the PRP, either we have to do the micro needling or derma roller on the face, and the same way the PRP is made for the vaginal regeneration, we put on the face also. Why we make the holes on the face or in the vagina? Because unless you don't do this thing, you have to put with the needles. It is more painful, and once there is a surface is abraded, you put the PRP, it will be enough to end the seep inside. As far as your training concerned, all of us from the INSARG and all the speaker who are here, everybody is doing the training and with a very value for money and economical way. Platelet rich plasma is always better. और क्या क्वेश्चन थे? आ गई डॉक्टर वर्षा?
Yes, ma'am.
Yes, ma'am.
Dr. Varsha has joined?
Yes.
Yes. I joined. Sorry, because till now I
Come,
was
Varsha,
watching
welcome,
everything.
welcome.
Yeah, I will share my screen just a minute. Huh?
Yeah.
Can you see my screen?
Yes.
Can you see my screen?
Yes, Varsha, उसको बस full कर लो.
I will start now. I'm so sorry. Okay.
Yes. Okay.
Okay. So, very good evening and sorry for this disturbance. Yeah, hota hai technology after all. Thank you, Dr. Parul, Dr. Sarita, my friend Dr. Ragini and Dr. Sheila Mane for giving me the opportunity to talk in front of this August gathering. So many I can see people have joined, and I'm going to talk on new updates in stem cell. Because what I thought, the previous speaker really gave good highlights about PRP, and I'm not going to talk anything about it. My talk is above that. I started my center in 2015, late 15. I used stem cells a lot for 2 years. I really worked very hard and did so many cases of no disorder, cosmetology, and whatnot, everything. But now you get evolved. I used to use cells. Now I am not using cells. So I thought I should give you the overview of what I am doing. Also, I have included infertility. Instead of only aesthetic gynecologists, though the topic is like that, I am injecting this mesotherapy, what I think is derma roller, and then injecting this activated serum, cytokine-rich serum that I'm going to show you in the last slide that I put on the patient face. Or what you do PRP, I do the same thing in the derma roller. This for hair rejuvenation, and mainly we give IV for anti-aging therapy, which it takes care of everything of the skin, hair, whatnot. So I'm not using stem cells. So what I'm using? I'm using exosomes. So stem cell therapy involves guiding stem cells into becoming specific cells into the body. They are found in several places, including embryos, umbilical cord, adult bone marrow, and fat. Now, in stem cell therapy, we give donor stem cells. They replace and repair the diseased cells. They grow and divide. What do? They divide and grow for a long time and do the healing of the cells over the time. So what is exosome therapy? Unlike stem cell therapy, exosome therapy doesn't involve using donor cells in your body. They are extracted from donated human mesenchymal stem cells and sterilized. So these contain the solution of exosomes contain soluble lipids, messenger RNA, microRNA, signaling cytokines and proteins. They are administered through IV or directly injected in the target treatment area. You can use it on the vulval area, you can use it on the hair, you can use it as a mesotherapy and whatnot. For local application also, you can use it with derma roller after all, because when you do derma roller, the absorption of the fluid or whatever extracted the solution is 1,000 times more. So exosomes are powerful element that can restore cells throughout body. They enhance cell-to-cell communication, which is essential for cell health. So compared to adult stem cells, they contain nearly 3 times more the amount of growth factors, and more growth factors definitely more the ability to restore and revitalize target cell. So we do not use cells as an entity to therapy, but we use the extract of these cells. Why not use cells? Because cell, there is a protein, so antigen, antibody, the titration and all the immunological factor we have to avoid. What are exosomes? They are extracellular vesicular structures secreted by cells in culture and found in body fluids. So how do they do? What is the biological process? Antigen presentation, apoptosis, angiogenesis, inflammation, and coagulation. All these processes are involved in exosomes. They can activate signaling pathway and deliver nucleic acid to distant cells. Their nano-sized structure, they are found in semen, epididymal fluid, endometrium, and follicular fluid. Also in testicular fluid, even in prostosomes. This is a cargo, which is a fundamental change in implantation like adhesion, migration, invasion, and extracellular matrix remodeling. They contribute to endometrial embryo interaction because I am an infertility specialist, so I am using it for human microenvironment successful implantation. So these are the exosomes. These are the exosomes in the extracellular fluids. So let us see about endometrium. The role of this there is a luminal epithelium in endometrium and there is a glandular epithelium. So this soluble secreted factors and exosomes are released by this luminal epithelium. Then it helps in the embryo comes after a few days in the endometrial cavity. Then the propectoderm position occurs, then attachment occurs, and invasion. All these things need exosomes for good implantation. They are the biomarkers for pregnancy because this particular mRNA is determined as a biomarker for all. When they get invaded, the secretions, they can be traced and we can see before when just pregnancy is happening, we can diagnose. So also it is used as a prophylaxis and in support of implementation of treatment. So these are the microvesicles, apoptotic bodies, and exosomes. These are all secreted from the cells. They are of different release pathways, biogenesis, function, content, and size, and accordingly they act on the cells. So this is a typical role of exosome in female reproductive system. In each and every part of ovulation to embryo development, it is helpful. Now, we have seen just now endometrial exosomes, how they do contribute with endometrial embryo interactions and good micro environment of the uterine cavities achieved for successful implantation. Now, exosomes is ovarian factor, follicle. See, this follicular fluid contains lots of components like proteins, hormones, and exosomes. It is very important for this follicular fluid for communication between oocyte and cumulus cell. So what do exosome do? The exosome limit the apoptosis of cumulus cells and support conception. So what is the benefit of exosome therapy? It is anti-inflammatory, anti-fibrotic, and easy to administer. It is used for nerve disorders also and more of degenerative disorders like sagging skin or aging or anti-aging, even in osteoarthritis, chronic pain, musculoskeletal injury, genetic disorder, chronic disease, degenerative diseases. And the natural process can be inhibited with the use of exosome because they increase the communication, the cell-to-cell communication, the channel are stimulated and thus the healing occurs. So they are used with the help of, their action is like anti-inflammatory, anti-fibrotic. It is very easy to administer them. They are just IV दे देने का. Strict product quality is needed and good lab and good sterility requirement are used for production of this exosome. These are the different pathways. So what is the function? Because the communication of ovarian follicle and cumulus cell is very, very crucial for follicular maturation and so embryo implantation. These extracellular vesicles are also, exosomes also, and ectosomes also. So what are the advantages? Because they are excreted from the cells and so they help in cellular homeostasis. The toxicity should not inside the cell. So they secrete, there is a metabolism of the mitochondria and cytokines and whatnot, and then they are secreted. And so the cellular homeostasis is equilibrated. So they are devoid of immune responses. So they are very much important for related disease and cancer progression. We can diagnose with the help of exosome. These secretions are titrated in the lab and we can diagnose. This patient is going to have cancer. Before that also we can diagnose it. So proteins, metabolite, nucleic acid delivered from exosomes in recipient cell effectively alter the biological response. This may promote or restrain the disease. Now just we have seen how it acts in the uterus. So this particular micro RNA and this one are very, very important for implantation. And this, if we titer it, we can diagnose this patient is going to conceive. But there are challenges for exosomes. The disadvantage is that they can be damaged during isolation and purification. The lifetime of exosomes in blood fluid and stability is also an important issue. We need minimum 100 to 100, 10 to 100 microgram of exosome for therapeutic dose. But the problem is the yield of 1 ml of culture medium is only 1 microgram of exosomes can be delivered. And the other factor also contain the composition, the volume of culture media. You must be knowing cell passage, 0 passage, 0, 1, 2, 3, 4. We develop the fibroblast in the lab and from them we extract these exosomes and the viability is also very important. So the use of exosome in regenerative medicine reduces the risk of side effects which are associated with cell transplantation. So no more cells are used. There is a passe stem cell use nahi karna. We have to use, why we are using stem cell? Because they carry all these materials which we extract and we use it. So there is no need of cells, so there is no need of immunological interference. So research has shown the lack of induction of immune response because of use of exosome therapy, which is the most advantageous. They can be used as biomarkers in the diagnosis of many reproductive diseases. They are the markers which help understand fertility disorders caused by dysfunction of sex organs or glands. So they are also used as drug carriers to be the feature of the treatments. How does exosome therapy differ from PRP? PRP, everybody is using. Yeah, you should use, because if you do not have that much knowledge, at least you should use what is available. PRP is a crude method of separating growth factors. I have tremendous data of PRP, which from head to toe, I have used it. It is good, no doubt. But now I have found better options, so I am using it. Because PRP is a crude method of separating growth factors which are bound to platelets, along with cellular debris also, which we are injecting and using it. Exosomes are more potent, rich more in growth factors, messenger RNA, microRNA, DNA, proteins, nucleic acid, and far more refined, sophisticated treatment, potent than PRP and more effective. They are derived from mesenchymal stem cell harvesting. So what are the advantages? Because they contain all these things more in amounts. So they are used in neurological condition, cancer also, for all anti-aging, local mesotherapy, everything. They can alter bioavailability of the drug to aid disease diagnosis. So this biological fluid, we can take them from liquid biopsies to diagnose the disease progression. Also, the response to therapy can be analyzed by exosomes. How to get the exosomes? Many kits are available. Long centrifugation isolation we can do. How to collect isosomes? They are collected from the biological fluid with centrifugation, filtration, chromatography, precipitation, and immunological suppression. Can we buy exosomes? See, stem cells, they are not FDA approved, do you know that? But there are stem cell centers. Many are doing, in Gujarat, it is the center is having 600 bedded hospital. So we are using it, exosomes. This is a new science, taking, it will evolve. They are still under trial and research. Are they better than stem cells? Definitely. To adult stem cell, exosome contain 3 times more growth factors. They are powerful element that can restore cells throughout your body. There's cell-to-cell communication, which is very, very important for anti-aging treatment, which is achieved with the help of exosomes. They enhance cell-to-cell communication for cell health. And more growth factors mean better ability to restore and revitalize these cells. So this is a typical mesenchymal stem cell exosome, which gives us these many immunological factors and these many growth factors. So they all help in rejuvenation. So what is the role of exosome? Also in male reproductive system, semen is a secretion of all these things. Prostosomes are having abundant exosomes, and the seminal exosome, which are 3% of semen plasma protein, protects semen sperm in acidic environment of vagina. So prostosome have the ability to modulate sperm motility, capacitation, acrosome reaction, and also prevent premature capacitation. So these are the effects of exosomes on male infertility. Now what this needs a sophisticated lab, because this is a sophisticated treatment. This needs sophisticated lab, and the lab should be handled by a sophisticated, well-trained geneticist who can give you the particular amount of concentration of the stem of the exosomes for the particular disease or anti-aging therapy according to the patient's BMI, age, and the problem and the chronicity of the problem. So and it should be stabilized also. You should give it to, because they should be as PRP also, they should be carried, or they survive well below 20 degree temperature. So we have other alternative also. The Sanakin, autologous cytokine serum. This stops inflammation and support reservoir to process body's own serum without trace of any cell is obtained, just like PRP, but better than that. Release cytokines are mainly growth factors, interleukin in very high concentration than PRP. Plasma is without plasma fibrinogen. It gives boost to endometrial regeneration, receptivity, also for all anti-aging procedure that we have been watching since long. Also increase the low AMH patient, develop more oocyte if injected in ovary, laparoscopy, or transvaginally. I used to use, now also I am using homologous, autologous bone-derived stem cells, which I segregate from my Sepax machine, and I inject it in the ovaries and the intrauterine cavity for the patient who got operated with for Asherman's. Fantastic results. But alternative to that, if the patient is not offering, you can use Sanakin, getting fantastic result. Patient gets spontaneous ovulation. Sometimes they get spontaneous pregnant. They get pregnant spontaneously also. So this is the procedure of activated cytokine serum, just like PRP, but it needs different kits which can be used for mesotherapy, for hair, anti-aging. It can be given locally, IV, everywhere, and this gives fantastic result. So it is a middle way of the treatment. So exosomal cargo is a key player in establishing diagnosis and executing therapeutic role while regulating a disease process. Thank you for your patient hearing. So I hope you have really got something different than PRP, and instead of going what types of stem cells and everything, I thought I will give you practical what I am using and what is clinically applicable. Thank you.
Thank you, madam. It was a great talk. Exosomes, nobody is doing here at our place, but of course, like hearing first PRP, then stem cells, now exosomes, it's indeed that we are, as medical fraternity, advancing so much and serving a lot to the patients. So, ma'am, it was indeed a great talk. Thank you so much.
Thank you, Vidya. Thank you, Ragini. Thank you, Apurva, for giving me the opportunity to talk in front of this August gathering. Dhanyavad.
Thank you. Thank you so much to our wonderful speakers, all the wonderful speakers, and for our chairperson for chairing the session so well. And
yes,
as I
chairperson Amrita, then the other two, I cannot see them, but
yeah,
thank you so much.
Vinita ma'am, and then Vikram.
Vanita Singh. Yeah. Shashi, I can see. Yeah. Thank you.
So after this really a wonderful learning, now it's the time to go to our next session. Yeah, and for chairing the session, we have eminent speakers, Dr. Shubha Sethia ma'am, Dr. Vidya Thobi ma'am, and Dr. MC Patel sir. So can I have the CVs, please? And to the delegates, I just, if you have in case any doubt, and just please share your doubts in the chat box. Our speaker will be really happy to answer your queries and questions. So our next chairperson is Dr. Sachi Srivastav ma'am. Ma'am is the medical director of the Saurabh Nursing Home and Specialty Clinic at Bhopal. Ma'am is the past president of the Bhopal Menopause Society, life member of Indian Menopause Society, POSCO and FOXY. Thank you so much, ma'am, for coming and joining the session. Next is chairperson is Mike. Thank you so much, Ragini ma'am, for giving me the opportunity. And our next chairperson is Dr. Vidya Thobi ma'am. Ma'am is the president of TASOGA of 2023. Ma'am is the chairperson of the Food, Drug and Medical Surgical Equipments Committee of the FOXY between 18 to 2020. And thank you, ma'am, is the governing council member and a lots of award in her credit. Thank you so much, ma'am, for coming and joining. Our next speaker, yes, he doesn't need any introduction. Our very own Dr. MC Patel sir. Sir is the past vice president, senior vice president of FOX 2018. Sir is the past medical legal chairperson committee of the FOXy, the organizing secretary of ICOG 2017 and whatnot. Thank you so much to all the chairpersons. And our next chairperson, Dr. Vidya Pancholia ma'am. Ma'am, again, a very dear senior and friends of mine. Ma'am is a dedicated, cosmetic gynae specialist, and ma'am is running the specialized cosmetic gynae clinic at Indore since last 8 year, I think more than 8 years. Thank you so much, ma'am, for coming and for giving your valuable time. Thank you. So I would like to invite the chairperson to please invite our next speaker.
Thank you for giving me the opportunity to be a very wonderful scientific session on aesthetic gynecology, because I appreciate the madam's vision and concept, because the aesthetic look is the main part of the woman's making more sound and confident. Today, this is the today's need to learn this art. We gathered the galaxy of stars. One of the stars is Dr. Vidya Pancholi from the center of the India, Indore. She is done her MS, FICOG, FCMCH. She is the master course. She has done the master course in aesthetic gynecology and super specialty in gynecological lasers. She is an obstetrician and gynecologist at Indore, master course in the aesthetic surgery and gynecological lasers from the Europe, running the state-of-art clinic, We Care Laser Center, the first of its kind in India, using RBM YAG laser, starting training center and Indore at Kochi. So, madam, we have eagerly waiting to listen you. The dice is yours. Thank you.
Thank you very much, madam. And with this, I'm going to start my presentation.
Ma'am, please minimize this, ma'am.
Yes, yes, I'm doing.
Yeah. Yeah.
Make it slideshow.
Yes, yes.
From beginning.
Madam giving the presentation on the vulvar dermatosis, which is the most common condition, and sometimes it is painful to treat.
Can you see my screen? Can you see my screen?
Yes, yes,
Yes, madam.
yes, Dr. Vidya.
Yes. So a very good evening to everyone. And at the outset, I am very, very thankful to Team ICOG, Dr. Parul, Dr. Sarita, Foxy team, my coordinators, today's convener, Dr. Ragini, and my DRS chairperson. And you must be agree with this statement of mine that talking about vulva and discussing vulval diseases always take a backseat in any CME or any conference. Though we all know that it is reasonably covered into undergraduate armamentarium of education, and it is also vastly covered in postgraduate programs. But being a clinical practitioner, I don't know why we are so reluctant for vulva, and sometimes I just feel that why it is so. Two things I could guess: that number one, most of the vulval diseases may be slight to moderate to very severe, starts with the irritation and itching. And it is because of disturbance between the superficial dermis and the deeper layers of skin. And there is a zone that is called hard line between keratinized to non-keratinized. Anything that disturbs there will definitely cause irritation. So the first presentation of irritation and itching always we take as a infective pathology. And to be very like say it is our common experience that because of some secondary infection or so,
these patients respond well to pan-syndromic approach. And when she comes again, we may add something or the other, but when she is not at all getting relief, she is losing follow-up with you. And that is the big point in the vulval diseases, that we are missing many of the things. Then the standard teaching of putting speculum directly into the vagina is the another reason of obscuring foreshead and the vulval area. And if it is a very, very small vagina with large speculum, things still getting mixed. So what I want to say, that if you have that vision of having a look on the vulva, if you have got that differential diagnosis in your mind, and if at all you can give some time to the histopathological pictures, then the things become so easy. And the day,
Ma'am, Vidya ma'am,
yes,
your
yes,
slides are not moving.
I am not moved any slide.
Okay, sorry. Yeah.
So basically, when you have that type of vision under your mind, under yourself, and then if you see these patients, you will really realize that what type of complications has developed into these neglected cases of our own. And because of that, ICOG and our conveners, they have decided to have the separate session on vulval diseases. And we are there in cosmetic gynecology and functional medicines. Now it is more than 10 years. We are so happy that with this lesion, with the differential diagnosis, and with the small gadgets that are available with us, we can revert many of the vulval diseases, or at least pick up on the right time to give her right direction. And many of the benign diseases can be treated with the tools of cosmetic gynecology, or the energy-based devices, or other regenerative form of medicine. So today I was given a topic, vulval dermatosis, and this is really very important to learn these vulval diseases. I have made my presentation as we are talking more on cosmesis, but the cosmesis part Dr. Ragini will take. So I am going to tell you about the vulval dermatosis, and made this presentation in an album form so that you can remember few of the things as a ready reckoner in your mind, and we can have joint hands to address these type of positions, or the clinical entities which are usually getting neglected, and they land into severe complications. This vulvovaginal consultation chart I like the most is advised by Edward Wilkinson. You can download from the internet. And I promise you that if you have this sheet in your file, any patient coming for vulval diseases or vulval problems, if somebody just fills this form, I promise you around 50 to 60% of diagnosis is made with this elaborate history. So anybody can download and have this type of form as a vulvovaginal consultation form. Mainly benign lesions of vulva, according to the International Society of the Study of Vulval Diseases, they are inflammatory, blistering, pigmentary changes, benign tumors, hematomas, and cysts, and congenital malformation. Usually they fall into this category. Now, if we talk about the cystic pathology of vulva, the first commonest is the Bartholin cyst. Very easy to diagnose, but very difficult to treat. Many patients go here and there for the recurrence. So best thing is to do excision followed by marsupialization on the first sitting. But if it is an abscess, just drain it. Don't do anything. Don't disturb the inner lining of that cyst, so that after some passage of time, you can marsupialize the same patient after when she gets settled. So if you go for the histopathology, there is a columnar epithelium. So if you can send a small piece for a biopsy, even in the Bartholin, you will be more confident to prevent recurrences. Second is the inclusion cyst, commonly seen. It is because of the entrapment of keratin and non-keratinized mucosa, followed by secretion of this vulval gland, and these inclusion cyst has that mucoid material inside it. And if you aspirate or excise that and send for biopsy, you will have both type of epithelium in inclusion cyst. Skinny's duct cyst, they are basically during around paraurethral or below the urethra, and they are very painful. Excision is the treatment of choice, and histopathologically, they have paraurethral glands or epithelium in the lining. You may see, recently I have seen multiple bilobed vestibular cyst. This is again because of the entrapment of keratinized epithelium and entrapment of some apocrine glands also, that leads to multiple cystic growth around the vulva. And again, the excision is the treatment of choice. Now, if you go for the macular pathology of vulva, you can see a case of lichen planus where they present with the erythematous plaques, and again, it should not be confused with the eczema, and treating with any cortisone cream will definitely give a good relief to that patient, and then you lost the follow-up. If this lichen planus is not treated properly, I tell you, I have a case from Mumbai, and visiting Mumbai and here, and finally she has landed into completely keratinized, obstructed vagina. You cannot even put a single finger into it. So after ablating this whole of the vagina with the surgical mode of our lasers, we could actually remove that keratin part, followed by we have to make a new vagina into this case. So this disease could have taken care in early, say 2 or 3 years before, if somebody has done biopsy. So this has typical epithelium with the keratinized, that is a keratinized epithelium that is pathognomic of lichen planus. And these patients are usually having ulceration into buccal mucosa, and this lady is going to gynec differently and to dentist in another sitting. So they cannot actually combine that this is because of the same disease. So initial stages, you can treat with the mild to moderate cortisone, but in severe cases, you can use lasers, and regenerative medicine can be a help to these patients. Lichen sclerosis, it's not uncommon. When you have vision from tomorrow itself, you will feel that this patient may not be having lichen sclerosis. Yes, it is prevalent and it is always missed with the vitiligo. These are having some very, very cigarette smoke type of appearance, and this disease is in a keratinization into very, very superficial layer. In histopathology, it is a very thin epithelium you will see, and you can see one more picture of advanced lichen sclerosis where she has lost all the anatomy and the fine structure around her clitoris, frenulum, and all labia minora, majora are fused. We are talking about cosmetic gynecology, talking about details of how to do labiaplasty. But there are large number of patients, dear doctor, who have developed the complications of these minor things which could have treated in the past. So what I want to say that these type of tools will help you in treating and fixing all the problems of this type of macular pathology of vulva. Vitiligo, yes, it is hypopigmented patch, and in histopathology are not going to get much. Vitiligo is not a very, say, dangerous because it is not causing any permanent damage. But yes, lichen sclerosis can obliterate urethra, the whole of the structure of the vulva, and what we can do in these patients, G shot, O shot, they all fail in front of these women. So we should have this type of vision, and that's why Dr. Ragini was saying that it is the functional medicine or functional gynecology with regenerative medicine that is emerging very fast, and cosmetic word is for few of the patients who are aware for or they are demanding for the cosmesis or beautification external genitalia, but there are large number of women waiting for you to help them. Papular region, very commonly seen, molluscum contagiosum. This is due to pox virus. It is painful, very contagious. Even the undergarments can affect the other person of the family, and usually these patients respond well to silver nitrate and TCA type of preparations. Sometimes they are self-limiting, sometimes they recur, and if they are larger size, you can very well ablate with your laser. Plaque lesion of the vulva, candidiasis, very easy to treat, but recurrences are very high. And sometimes we are fed up of giving antifungal to this patient, and she also says, doctor, how many times you will write me this medicine? I am fed up. It is always there after sexual intercourse or after my menstrual cycle. So the problem in the vagina, that it is the acidic pH that has occurred because of recurrent infection. So gynecological lasers, a very soft mode of laser, actually maintains the collagen, the pH, the glycogen, and the acidity of, or the acidic pH of vagina is well maintained, and then these patients respond well. So antifungal acute treatment, I am agree, but after that, you can help this patient with the gynecological laser. Lichen planus chronicus is a condition where the epidermis is the stratum, the outer air, the epidermis is affected. It is thickened. Irritation is always there. And when it is in the advanced form, it may cause distortion of the labia majora. So a very good these cortisone creams, and then excision of the nodular area if it is developing, or laser is the treatment of choice. Paget's disease, again, it is a Paget's is amongst the 60 plus women mostly. Irritation is always there. And then in histopathology, there are Paget cells inside the mucosa, beneath the epidermis. So it is a intradermal neoplasm, we can say, and they are responding well to, again, cortisone, 5-fluorouracil, and laser treatment again can be offered. The psoriasis vulva, they are looking like a eczematous, but it is not eczema, it is autoimmune, so respond well to cortisone. And there is a again that cigar powder appearances, because there is a breach in the continuity of the keratin layer of the vulva. So that is the histopathological form. So I think from initial to up till now, if you go for a small piece of biopsy during treatment, you are very safe and patient is also safe because you will not miss anything. Then VIN, again, the intraepithelial neoplasm, they can also come as a irritation, itching, or some erosion or breach in the continuity of the skin, and biopsy is the final answer for VIN. And here, non-ablative lasers, or if the lesion is not exceeded too much, then even invasive lasers can revert the disease. Now, plaque type of lesions of vulva, endometriosis, easy to diagnose. And if you don't want to jump into any of the surgical procedure, then simple dynogest or anything that can shrink or that can show a small response will also give you diagnosis. But if there is a big endometrium, then you have to fulgurate. Hydroadenoma vulva, this is the entrapment of apocrine gland into the epidermis, and they actually shows a continuous leak of mucus. So in this case also, excision by laser, by cold knife can do, but histopathology one should do. Leiomyoma vulva, just simple aspiration into the OPD will make a diagnosis for leiomyoma. Excision is the final treatment. Ulcerative lesion of vulva. The first picture what you are looking at is the depressed ulcer, and this is always there with the patient of HIV. And serology, Western blot is the diagnostic tools. But if you go for the histopathology, there will be typical lesion of vasculitis and the related histopathological findings. The second is the chancroid. They are very, very painful due to this Haemophilus ducreyi, and these are suppurative lesion, and they respond very well to erythromycin or the doxycycline and drugs, and completely the disease reverts. Herpes, these we cannot miss because we used to see lot of patients of herpes, and these patients are having three types of categories. One is the acute one, where they can be simply treated with the acyclovir or the local acyclovir. But if they resolve, then after some times they may come with the systemic problems of fever and body and the bony lesion, and if missed, then they may develop cardiogenic and other vascular problems. So stop it in primary phase. The another is the sarcoma of this vulva, where the lesion is under the epidermis, but not very, very superficial, and this is highly malignant. So a picture like this with biopsy, if diagnosed as a sarcoma, we can take steps quite early in the phase of diseases. Decubitus ulcer, this is also very common because of compression. Standard education and cleaning and few antibiotics can help these patients also. Now, lymphogranuloma venereum, due to this chlamydia, it is chlamydia L1, L2, L3, and these type of diseases have first this type of warty or ulcerative look, and when it is treated with the erythromycin, doxycycline, tetracycline, disease can resolve. But if patient is not doing proper follow-up, if disease is not completely resolved, then this actually blocks the lymphatics of the vulva, and then there will be a lot of edema, and sometimes there may be elephantiasis of the vulva. Syphilis, again, ulcerative lesion, not painful because of Treponema pallidum. Again, this disease is also goes into 3 phase. In early phase, it is very, very much treatable with the penicillin. But if missed, then it is the secondary and tertiary syphilis. There are a lot of ministers, they are actually lost their life because of syphilis. Then squamous cell carcinoma, if it is a very advanced phase, anybody can pick up by look or the biopsy. But if you think that this is not a type of vulval diseases commonly I am looking at, you can straightway go for the biopsy and send to the proper center who is taking care of the vulvectomy and whatever advanced treatments are available. Hidradenitis with malignancy is also very commonly seen because the apocrine glands get entrapped and they secrete the mucinous secretion, and the proper, the primary disease always lies with them. Now, one more thing is the Behçet's disease. This is, you can't forget if you just see how the Behçet's looks like. It has a very circumscribed, very dark lining of the vulva, and Behçet's is basically because of genetic and immunological reason. So the therapy will also be symptomatic, followed by 5-fluorouracil or proper drug treatment to have to prevent the recurrence of Behçet's diseases. So, dear friends, chronic inflammatory dermatosis can be lichen sclerosis, planus simplex, dermatitis, psoriasis, infection group, fungi, viruses, sexually transmitted diseases, and parasite. Pre-invasive lesion can be there, and secondary causes may be there. Every lesion may not be the proper, we can say, having organic cause, but allergy, diabetes, estrogen deficiency, they all can have this type of vulval pruritus. So don't take vulval pruritus very simply giving them antifungal, azithromycin combination like Fasricate, Bisticate. So what I want to say that if you give these drugs, she will be happy, but don't forget to call her again and again for at least 3 months after your primary therapy. So role of aesthetic and regenerative medicines is quite more, and these are few very important papers. I am using erbium YAG laser that I found is the safest, and it is meant for gynecological use, and it is FDA approved, and not only in the US but Singapore. There are a lot of approval papers with this laser, and we are using smooth mode that is used. So this is the paper, and one is the platelet-rich plasma in lichen sclerosis. The details about the cosmesis, where we can do, what type of help we can do with cosmetic procedures, will be taken care by my dear friend, Dr. Ragini Agrawal. So I will stop here. Thank you very much. And sometimes I felt that I was audible or not. Apurva?
Yes,
Absolutely, you
madam.
are
Very
audible,
well
ma'am. You are fantastic, ma'am. Thank you
Thank you.
so
Thank
much.
you
It
so
was
much.
a great,
Yeah.
great talk. Yeah.
Yes, madam, you have covered each and every aspect of the vulval lesion and very nicely covered in a very short time. And what the consequences if not treated timely.
Yes.
Wonderful job done, ma'am. Wonderful.
Thank you. Thank you so much.
Thank you. Thank you so much, Vidya ma'am. Thank you so much, Chairperson. We will move to our next speaker. Ma'am, can you just unshare, Vidya
Yes,
ma'am?
yes, I am doing. I
Please
am doing.
unshare your screen.
Yes,
Yeah.
yes.
So our next speaker is none other than but our very own Dr. Ragini ma'am. It's really my privilege to invite our chairperson to introduce our next speaker, Ragini ma'am, though she doesn't need an introduction. So Vidya ma'am, can you just do the
Yes,
needful?
yes. It is always, always a pleasure for me to introduce Dr. Ragini. She is my dear friend and my guide and mentor also.
and and very dear to me. And we know that she has got so much passion for this teaching, and especially the aesthetic gynecology.
I think that is enough.
Yeah, that is enough. And we can see her so many awards and so many. I think in Haryana, she has founded, so she's a founder, president of so many organizations. That is her, what I must say, that is her recognition. So over to Dr. Ragini. She is going to talk on
Just
cosmesis. Yeah, cosmesis.
just to add it, ma'am, the
Yeah.
Haryana actually IAG is going on. And
Yes.
ma'am is the main chairperson, organizing chairperson, and still she got a time for this cosmetic gynae workshop.
She
So
is a
thank you so much, Ragini
multitasker.
ma'am.
She is a multitasker.
Absolutely, absolutely,
Yes.
absolutely. Yeah.
Thank you so much, everyone.
Over to you, ma'am. Yeah, Ragini.
So we are most of the talk is covered by Dr. Natasha and Dr. Vidya. I think there's some overlap in my mind, and I have kept these overlapped um, talks. So I am added few new things in my talk. That is what we have missed. That is the idea. And there's some questions which we have seen, specifically how to give the Botox in the these cases of the vaginismus. So instead of going towards totally vulval cosmesis, which we have almost covered in the Dr. Natasha's talk, I am going more to focus these two problems which we really have in our OPT, that is vaginismus and vulvodynia. There's one personal message to me from someone that what you're talking about the gynecology. What is special about it? My dear friends, have you ever thought of vulva before this cosmetic gynecology or aesthetic gynecology we have started talking? No. Vulva is absolutely forgotten organ. What gives the vulva this exotic thing is a labioplasty. And then when we changed our track from the only cosmesis to have a good life, quality of life, our patient, we have came to know vulva is having so many problems and we are neglecting it. Either woman is suffering or we are sending to dermats or other specialty. So here our this subspecialty, which I called very proudly, I called aesthetic, functional and regenerative gynecology. I'm not making fool of any of my colleagues. The people who are focused on the cosmetic gynecology, and they are not promoting functional gynecology and the regenerative gynecology. I think they are doing injustice with a subspecialty. They are doing injustice with the women folk, and they are doing injustice with the our friends. So coming to this vulva, which is a collective term for the external female genital organ, with a beautiful presentation from the Dr. Prerna, we have totally relearned our vulval anatomy yesterday. So today, my talk of the lights and laser in the vulvar disorder and regeneration is covered by Dr. Natasha in part, as she has talked about the laser in the vulva, because laser or people are using RF. So I can say it is a energy-based devices. They are doing wonder when we talk about the cosmesis, when we talk about the diseases, what Vidya has spoken detail. So why we are talking about the vulval cosmesis? Because the patient is aware. They are coming to us and they are asking. And why we are promoting energy-based devices? Because they are the better precision, sparing the normal tissue, probable elimination of the infective agent also when we use in cases of the molluscum contagiosum, in the cases of um, warts, because when we just cut the wart, we are not going to deep. When the shaving the wart, the wart comes up again. But when we are using lasers or the energy-based devices, the coming of the and the remission and then relapse of the wart is very, very less. There's a rapid healing, lesser complication, reduced treatment duration, enhanced result, and enhance the aesthetic aspect. No keloid formation, no scarring, and greater confidence and the self-esteem. So common laser symptoms in our gynecology, we have only these three: carbon dioxide, Nd:YAG, and the diode laser. And other laser are not with us. We are mostly use only these three lasers. Where is my, this is gone. My voice is
Hello.
gone. Hello.
Hello. We are able to listen to you, Randevi.
I'm having lots of technical problem.
Yeah.
So,
But make it slideshow. Make it slideshow.
Okay. Okay. So today what we have talked about the pigmentation. That is the most important thing when we talk about the cosmesis, whether it is a hyperpigmentation or the hypopigmentation. Here the problem starts whether it is just for the cosmesis purpose or it has some underlying disease also. And the exophytic growths, which is a very common, although Dr. Vidya has given us a very detailed thought. But what I want to focus only for the very few things which is commonly we see in our OPD, and the most common thing is the genital warts. Now that when we talk about the genital warts, we have to think about the anogenital warts also, because today with the way of practicing sexual thing in the society, other type of the sexual activities are also there, and patients are coming with a anal wart like anything. So this has given me a thought: when we are talking to our patient, we should always talk to about having these type of the sexual activity also, and tell them please use condom when you are having this type of activity. To saying that we are not ready to talk about it is not wrong, because whenever an anogenital patient comes to me with an anogenital wart, it is really very painful to me to see these women, because they are not aware what they are having and where they are landing. Then molluscum contagiosum is another thing which we are sending to the dermats. And no doubt, lichen sclerosus. Someone has asked the biopsy, how we do the biopsy. Please, when you do the vulval biopsy, remember only three things. That the time of doing a big biopsy has gone. When we do the biopsy, there are punch biopsies available in the market. 3 mm is very good. You don't need a big thing. When you take the biopsy, you have to pinch up the skin little bit along with the little dermis also, and you have to just screw the that punch on that. And yes, a small piece is there. Maybe you need a small scissor nip and take that piece. Many a time you just press it. You don't require even to put any suture in it, and bleeding stops. Now vulvodynia I'm going to take in detail. Hair reduction is taken by the Dr. Natasha in detail. Somebody has asked what type of the laser we use for the hair reduction. For the hair reduction, Nd:YAG, diode, and the IPL is three techniques which are being used. Carbon dioxide laser is not for a hair reduction. Diode is for hair reduction. Then when we come to the vulvar rejuvenation, we have to see the skin laxity. What we are going to see, that whether labia majora is at fault, labia minora is fault, whether the whole area is wrinkled, whether the area is having irregularities or dryness, itching, what is the texture of that area, or how the episiotomy scar is placed. Sometimes episiotomy scar is very much deep and it is giving a shrunken appearance. Patient is having pain in that area. And the one thing we have to again focus, that is a patient's forecheck. Many times patient forecheck is little bit abraded all the time. So these are the area where we focus, and we have got a very wonderful talk of the PRP. So dear friends, I can tell you in these patients where there's a non-healing problem, there's a scars, we can resurface it and put the PRP in there And the wonderful healing is there. Even the lots of dermatosis with the Dr. Vidya has shown when we treat them with their disease, and it left with the scar, it left with the open area, unhealing ulcer. So in that time, after biopsy proven there's no ulcer, there's no other disease, we can use the PRP here also. So patient selection is very important. We are doctors, we are not a beautician. So we have to take the history. Patient coming the whole black vulval area, extended up to the groin. Many a time it is a comorbidity of the hyperinsulinemia. Patient may be pre-diabetic. And unless you take care of that comorbidity, that area is not going to get cleared. And any infection, any abnormal bleeding, these are the pregnancy, we are not going to use any procedures. So pigmentation, I think Natasha has covered, but we have to remember there are the 4 types of the hyperpigmentation: physiological, post-inflammatory, acanthosis nigricans, which is very common with the PCOD girls, with the obese women, and the pre-diabetics and the diabetic patients. Then frictional vulval menosis is increasing because of the tight clothes the girls are wearing. There are lots of PV discharge, and the area is moist, and the frictional melanosis we are seeing in many cases. Then there's we require vulval bleaching in many cases. Again, in Dr. Natasha's talk, we have seen how we take the combo of the laser and the peels. So when patient comes to us, first thing we have to decide between normal or abnormal, and accordingly we have to go for the treatment. Acanthosis nigricans, comorbidities we have to take care, that is very, very important. And there is many times there's a bit of the vaginitis with the itching, and we have to see whether there's a mechanical rubbing or the repeated infection. Either we go with a Q-cis laser or Nd:YAG laser, and these are the parameters which are, most of us don't have this thing. So mostly what we do in cases, if we have one machine, either it is a radio frequency or it is a carbon dioxide laser. In both cases, we should know our setting. And I am a person with a carbon dioxide laser, somebody is using radio frequency, somebody is using erbium YAG laser. And as far as I know, everybody is happy with their machine and it is giving good results. Yes, RF is very good when we are using for the wrinkling, we are using on the face, we are using on the neck. Here, carbon dioxide laser is not the equipment to use because it leads to too much of the PIH. When we talk about the vulva and the vagina, carbon dioxide laser is an excellent tool. It is a microablative laser and with comes with a different type of probes. It gives a very good cutting, specifically in the cases of the warts, in the cases of the molluscum, in the cases of the tax. So it gives a small columns, which was maybe dealt on the yesterday in the laser with the Tanuja. So remember it. It is just like a small aseptic burn wound between the normal skin is there, which regenerated. So we had a handpiece, light scan, with which we can do it. And energy, always keep low. Don't put the lots of energy, and there's a remodeling will occur with the time. This chemical peel combo, Dr. Natasha has also shown to you. There was many questions. Normally, we use the glycolic acid and the lactic acid in the private part. No yellow peels and all is used on the private walls. Some companies has come with the intimate peels, which is a combination peel, and in between you can give a cream also. Mostly those cream has a vitamin C and the glutathione. So vitiligo, we have to again, when the patient of the hypopigmentation come, we have to see the cases of vitiligo, psoriasis, and the lichen sclerosis. If the patient of the vitiligo comes to, it's better to send to a dermatologist. It is not your field to go with it. So exotic girls, I will not touch much because Dr. Vidya has given it a very detailed input in this. I'm just coming to directly what I want to say, talk to you about the part of vulval regeneration. So we have to identify the concern. As I told you, laxity, texture changes, wrinkling, pigmentation. And patient is aged, we will get the dryness also. Itching is a compound problem, and we have to see about the scars, give episiotomies, and we have to offer a complete package to these patients. They many times there's a combo treatment is given, and we have to look upon the general condition of the patient also. It is not only that a patient who is having anemia, patient is having a low vitamin D, B12, and the protein deficiency, they are not going to be get relieved if we don't take their holistic approach towards their general nutrition. So vulval regeneration, when we talk about in the non-surgical method, there are many type of things are available with us. Topical medications, specifically in the older women in the form of the estrogen cream, and because it will take care of the dryness, we can use the icerin gel, that is a soya gel. It is also very good, and in some cases we have to use the available moisturizers, vaginal moisturizers, and the lubricants. And this lubricants, understanding of the moisturizer and the lubricants is very necessary to all of us, because it can be used in the earlier very mild case of the vaginismus also in these patients, when they say they can want to treat themselves with the help of the dilators. Then coming the laser therapy or RF therapy, it can be used to various vulvar condition, and here our way of treatment is that to give the energy which causes thermal heat shock protein production, leading to neovascularization, collagen reformation, and leading to healing of the skin. The same with the radio frequency and the laser, they both work together. PRP injection, you have seen in the details. PRP is injection, again you can insert in the labia majora and labia in the even in the mons area also, and it again causes the increase of the growth factor there. Then we have a filler injection for the volume replacement. With the age, even without age, many a time when we see the labia majora, it is flattened, there's no fat is there, and it looked like the empty nest. In those cases, previously we has a lots of filler, but filler is a very costly affair. So now we have replaced this filler mostly with the combination of the PRP, threads, and autologous fat transfer. Again, autologous fat transfer is a wonderful thing, but many of us is not trained to make the nano fat and taking from the liposuction. So for us, in the beginning, it is good if we start using the PRPs and with the laser, and along with, if we are comfortable, we can start with the thread also. So these treatments typically require multiple sessions. This is very important. Either laser, we give the 3 to 6 sessions with the interval of 1 month, but with the thread and fillers, it is about 1 year to 6 months to 1.5 years, depending upon the patient's composition. So filler used primarily for the increased volume, making significant alteration to the vulva, other characteristic like the skin quality, color, or shape. Then we have a surgical correction. The next talk is going to by the Dr. Mayuri for the surgical correction of the vulval area. So what is the vulval thread? That is a newer method for the vulval regeneration. They are the absorbable threads and have a reliable reputation in the aesthetic market, and absorbable thread made of the polymer have been extensively used. What we this vulval thread is available in the our country. So what the other for the face threads which are available, we use those threads. They are mainly Cox threads, which we use in our laparoscopic surgery also, the same type of smaller threads come. Once you inject it with the cannula inside the vulva, they really hang there. You cannot take out, and gradually it absorbed, leading to fibrosis and the growth infiltration products and the increase in the size. So it is used for the labia majora augmentation. Clinical effect of the thread insertion persists for a minimum 6 months, but mostly patient they have a 1 year also. Absorbable thread insertion in the subcutaneous layer of the labia majora to improve the aesthetic parameters. So in this way, we insert the thread, fine wrinkles in the vulval area, loss of tone, mild ptosis, other aesthetic defects in the labia majora, loss of volume or loss of shape of the vulvar area. Usually, along with this, we always first go with the laser tightening and the laser cleaning, and we give few combo peels also to make the area light, and finally we put the threads. So this is a well-known synthetic polymer. Its ability to degrade slowly over a longer period and also a biocompatible, and they have a two substance in it where we will not give it allergy to material. Previously planted permanent fillers, we are not using now permanent fillers. We are using hyaluronic acid, which is a biodegradable, natural product, active phase of infections, where there is anticoagulants or antiplatelet medicine is given. Patient is having dysmorphophobia, body dysmorphic disorder, or having other acute infections. So we advise patient to have sexual abstinence for 2 weeks and given to patient to avoid any prolongation of the post-procedure recovery like swelling pain. They have to come patient or follow to 7, 30, 90 and the 180 days. Here only one session is required, and shape of labia majora after treatment is elastic, naturally turgid, certain volume is needed. So when in those cases, we have to give little bit PRP also. Biostimulation provided by thread lasts more than 1 year. There is no risk of the vascular occlusion. As far as the filler is concerned, they are the same as the dermal fillers are there. They are naturally absorbed over the time. Hyaluronic acid is the preferred one. It is a natural substance. High concentration is found, and it is embodied in the cartilage, joint fluid. In big way, it is PRP is being used, and these fillers are being used in the orthopedics also. It is extracted and reformulated, and so many indications are there. In the face, it is really in a big way. We all know that the fillers has a big market as far as the facial aesthetic is concerned. But here we are using for the labia puffing like the face. G-spot amplification is again done by the hyaluronic acid fillers. So coming to the next part, think I have to log out and open again. I have to log out and just a minute, please.
Dr. Ragini, you will be showing some videos of injections and all.
No, we cannot show video in such a open forum because they are mostly taken by the patient, and we have not taken the consent for the open forum for the videos.
Okay.
So for the videos, if you contact any of the speaker, they all running the courses. We cannot show here video in a detail. So I'm just coming directly to this particular.
Make it
I'm doing.
Yeah.
So this I have seen a question people have asked about the how to give the injection in cases of the vaginismus. Botox is, injection, how it is here. The two things is very important when we talk about the vaginismus. When this patient comes to you, please be too empathetic with them. Talk to them. There's many consultation is required before you are going to really examine that patient, and most of the case you are unable to examine. So when you do the vaginismus patient, first just sedate them, see the tone, and if you are able to do it, go ahead or give a general anesthesia. Because after giving the general anesthesia, almost muscle tone has gone. So it is very difficult to see the muscle tonicity. Number two, when you examine your general patient, try to make this in your mind, examine them properly and palpate the muscle and understand the muscle. So it is in your mind when you are going to give the inject. That's why we kept the first talk of the Dr. Monica for the understanding the pelvic floor anatomy. So this whole levator ani, you have to give the Botox injection. Normally we use 100 to 150 unit Botox. Normally 150 unit Botox is required, 75 one side and 75 other side. The most important thing, never give on the 6 and 12 o'clock position, because here is the 6 o'clock position, you have your anal canal, and the 12 o'clock position you have your urethra. If the Botox injection is given in here, patient will have a involuntary leakage of the stool and the urine. And this is the only and only complication which, although it is very rare, you have to tell your patient that you may have this temporarily leakage for 3 to 6 months. But it never happened, and you have to take a bigger needle. Here, a small insulin syringe needle will not going to help you when you are going to give the injection in the levator ani. So remember your levator ani muscles, part of the puborectalis, pubococcygeus, and the bulbospongiasis, and little bit you are going to inject in the introitus also. So what happened when you give this injection? After the giving the injection, put a big mold inside. So when the patient will awake, see this mold inside the vagina and not able to feel. It will break the pain cycle in the mind. Many patients of this type are having a sexual phobia also because of the childhood trauma and all. So they need a psychotherapy and the sexual therapy also. So remember, you have to talk about the Botox. Botox again is a very costly affair. A single unit will cost you something like 300 to 350 unit of the Botox. So when you give a bulbar cavernosus, inject in a part and part, one proximal, one inferior, and one distal bilaterally. It is very important how do you give, and it is better if you give the little bit lignocaine afterwards in the surrounding area, so the area is anesthetized when patient is awake. It is still, because properly Botox is going to take complete effect in minimum 3 to 6 days. So patient should be informed that she's not going to having an effect immediately, and lubrication should be given because there's a natural lubrication is down, and afterwards patient will have intercourse but she does not feel anything, and husband is able to feel, and most of the patient it is successful and they never need another injection. So the second thing is a vulvodynia. We all know that vulvodynia is a problem exclusion, and it is an idiopathic pain disorder. Many times this vulvodynia patient, not the generalized vulvodynia, but the focal vulvodynia patient are more with us. And when these patient comes to us, many our vaginal surgery can also cause a little bit vulvodynia in many patients, specifically cervical conization, LEEP procedures and all. And after this laser, we are able to treat this patient very properly. So in these cases, there's lots of therapies there, and no therapy is really going to do any help to this patient. Vestibulectomy is a very, very dreaded operation, and it is a debilitating operation. So if you see this properly, this vulva, it will show you where you are going to give your shots of the laser. So this is the area, this whole area of the labia minora inner side, and this vestibule is the area where we are going to put our shots. Sometime inside the vagina also patient complain that a particular pain point they feel a pain or a problem. You can put your lasers at a very 26 to 21 millijoule and give energy for a say 10 seconds or so. So after 2 or 3 sittings 1 month apart, these patients respond to very well. So that's why we have taught you in detail pelvic floor musculature, innervation, and this is a very necessary again that to ask the patient this question when she experience pain, how much time it is there, and whether it is only when she feel by herself or it is during intercourse or only putting a tampon or not at the time of tampon. You have to do a visual examination, cotton swab examination, neurosensory examination, and pelvic floor muscle examination, and evaluation of the comorbidity and the factor. So this is a type of the vulvodynia which you found in your patients, and mostly these patients have a provoked vulvodynia, and mostly these patients have a near the fourchette area or in the lower side of the vulva. They talk about the vulvodynia. So we have to rule out the severe patients. Sometimes they come with the arrhythmia, and we can confuse with the vulvodynia. And these type of the patient, first we have to check their arrhythmia, treat their arrhythmia. Only then we have to go for the vulvodynia treatment. If you see in this patient how we give the swab test and see every portion, and these are the only portion where we are doing the swab test, we are going to give our laser energy. I have never worked with the RF for this thing. I can't say maybe RF also work for it, but I'm very comfortable with the carbon dioxide laser, and it is giving me a very wonderful results. So we have to go a individualized multidisciplinary treatment in a regime which is recommended. And most of the patient, they have an improved mood and the psychological after doing these treatments. Plain block medicine, not much of effect, although it is written there. Topical formulation, not at all. They are going to give any effect to them. Yes, nerve blocks are sometimes very nice, but how many times you can give up dental block? It's very difficult. Pelvic floor muscle therapy, again give in many cases when you release those facial trigger point, they are very good results. But in a real case of the vulvodynia, they are also not going to give a very good results. Where you need by these giving the energy-based devices, basically these nerve endings are attenuated and patient get a good response. So laser treatment for vulvodynia, carbon dioxide fractional laser therapy is found effective. Surface lased by light scan, 3 to 4 sitting is required. And so this is the points where we can give to this patient, and we can map these things before starting the laser where the actual point of the vulvodynia is there. So friends, with this, I will stop, and I hope it is enough for the day for all of you, and we will move forward.
Thank you. And really, it was a very informative talk, Dr. Ragini. We learned a lot about the lasers and its right use in our practice, at least when to refer to the patients. Otherwise, the people, they just go on prescribing creams and other things. But the diagnosis is very important. What is the cause for the pain and the treatment part. So you have covered almost everything. So any questions, please put up in the chat box. Dr. Ragini
There are
would
lots
love
of
to
questions which
answer.
I'm so sure saying. Somebody
Yeah,
has
yeah,
asked
there
to
are
show
so
the
many
slide
questions.
of peels.
They wanted to see the slide of peels. So if it is
Okay.
possible for you to see.
Yeah,
show.
yeah, I can do it because the next speaker is waiting. You can
thank you. Yeah.
always talk to me on my
Yeah.
phone number. I'll just show you. Okay.
Okay. So thank you, Ragini ma'am, for the wonderful talk. And so we'll move to our next talk.
Just I
And
will show them the
showing,
screen.
1 minute, 1 minute. She's showing that peels, and then we will switch on to the next talk.
Yeah. Sure, ma'am.
This is the chemical peel. Please take the photograph. Okay. This is a peel combo which we use normally.
No,
And,
but the name we will not know. No,
there is
this
one more
combination is
question. How
available.
much time we have to keep? It is on the how much strength you are using, 5 to 10 minutes. Then wash with the water and apply the moisturizer or the. If it is on the face, you have to use the sunscreen. But in this area, moisturizer is enough. So thank you so much. You can contact at any time on my phone now.
Thank you. Thank you so much, Ragini ma'am, and thank you so much for sharing your number. I think people will definitely benefited from you, and definitely me and many others are really benefited from these talks. I would like to invite our next speaker, the very dear friend of mine, Dr. Mayuri from uh, Jaipur. So, Dr. MC Patel, sir is there? No.
No,
So,
sir.
any chairperson? Vidya ma'am? Yeah. Or Shashi ma'am? Anybody,
Yes,
please introduce
Dr.
our next
Dr.
speaker, Dr.
Mayuri.
Shashi.
I'm there. So
Okay.
Yeah.
I will introduce her.
Okay.
A young, dynamic Dr. Mayuri Kothiwala, who is from Jaipur. She has got various degrees and memberships, and her main interest is cosmetic gynecology and gynae laparoscopy surgery. So I must listen to her. Everybody should listen to her. And over to her talk. Dr. Mayuri, can you share your screen?
Yes, ma'am. Thank you so much. Thank you, Apurva. And hi.
Thank you.
Thank
It's
you,
really
Ragini.
wonderful meeting you virtually, Mayuri.
Oh, thank you. I am observing you since the last 2 days. You are doing a very good anchoring and everything.
Thank you so much. Yeah.
I think it's visible to everybody.
Yes, absolutely. Please make it full slide.
Yeah, thank you, Dr. Ragini ma'am, for this wonderful opportunity. And it is indeed a privilege to be among such young, esteemed colleagues and experts in this field. I'm truly honored to share my insights and expertise on surgical vulval aesthetics. Though this topic is very vast and it's difficult for me to cover in 30 minutes, but still I have given my best and I've included lots and lots of photos and videos so that it makes understanding very easy for you. So please don't miss out on the slides. As we are already running late, let's begin. We all know that the anterior and the posterior boundaries of the vulva extend from the mons pubis to the anus, and laterally the boundaries are at the genitocrural folds. The vulva includes mons pubis, labia majora, minora, clitoris, clitoral hood, frenulum, vestibule, and the vestibular bulbs, hymen, Bartholin glands, and the Skene's glands. The patients might present to us with the complaints of hypertrophy, asymmetry, wrinkling, and discoloration of the labia minora or majora. The presence of scar tissue or tears or skin tags in the perineum. She might also present with embedded clitoral glands in cases of lichen sclerosis or other chronic inflammatory disorders, hypertrophy of the clitoris, excessive skin folds in the clitoral hood, or vaginal loosening, loss of sensations, and ruptured hymenal tags. So if we answer these concerns, it will help her in boosting the self-esteem of the patient and building a positive body image, enhanced sexual confidence, improved physical comfort, and maintaining a personal hygiene. So although there is no globalized standard genital aesthetic ideal, but the basic guidelines for genital aesthetics include symmetrical labia minora that do not protrude past the labia majora, especially when standing. The hood is reasonably short and not protuberant without extra folds. The full labia majora without redundant skin, but not overly fatty, which can cause an unsightly bulge in the clothes. And mons pubis that has mild fullness but doesn't protrude in the clothes. So vulval cosmetic surgeries, which I'll be covering in this presentation, include the labia minoroplasty, clitoral hood reduction, perineoplasty, hymenoplasty, and labia majoroplasty. So beginning with the labia minoroplasty, it has been seen in the last recent years, since 2015. It has been published in various journals that there has been rise in the incidence of labiaplasty surgeries to almost around 73% from 2015 to 2020. And the reason for the increased demand is increased awareness and openness among the patient. Media coverage and beauty standards have changed. Accessibility to the information has become more easier for the patients. The reduced stigma surrounding cosmetic procedures and improved surgical techniques and safety. We all know there are huge anatomical variations in the areas of clitoral labial complex. The normal length of the labia minora extends from 2 centimeters to 10 centimeters and the width from 7 mm to 5 centimeters. And there is no formal guideline to indicate when to go for surgical correction and when not. But the labial hypertrophy has been defined as maximum distance from the base. This interlabial fold is just the base of the labia. And when we measure from here, when it is greater than 4 centimeters, it is called labial hypertrophy. There is a segmental blood supply within the labia minora. One central dominant central artery, one anterior and 2 posterior arteries, which are the branches of pudendal arteries. And we should respect this anatomy because disruption of this segmental blood supply is responsible for wound dehiscences in cases of labiaplasty. The medical indications include chronic discomfort, pain, interference with daily activities, hygiene challenges, labial hypertrophy, recurrent infections, and all. And aesthetic indications include desire for symmetry, cosmetic enhancement, improved body image, clothing comfort, appearance, and reducing emotional distress. This image is of one patient of mine. She came all over from Dubai just for this small asymmetry in both sides of the labia. So you never know which patient is suffering from what disturbance in her mind. In preoperative assessment, after a detailed medical history and physical examination, informed consent should be taken about the description of the procedure, alternative options, expected benefits from the procedure, post-operative care and recovery anesthesia information should be provided to the patient. So there are numerous techniques described in the literature for labiaplasty, but the most commonly done used techniques are the wedge excision, trim resection, and the de-epithelialization techniques. In the trim technique, asymmetric or protuberant labia minora can be corrected by excising the excess areas with knife, scissors, laser, RF device, or anything. It is best for marked redundancies, excessive thickness, and when the patient is accepting a potential change in the color of the labial edge. Advantages of this technique are the short operative time and the creation of light colored labial edge. It might be preferred by some patient to have a light colored labial edge, and they might prefer trim technique over the wedge technique. In the trim technique, the incision starts from almost 1 to 1.5 centimeters below the frenulum, and it's extended down to the introitus or perineum, depending on the precise location to which the labia minora is attached. It is imperative to leave a 1 centimeter cuff of labia minora to retain a functional seal of the introitus. Otherwise, if you excise too much of the labia, it will give an open and gaped appearance to the introitus, and it will not be aesthetically good. A layered closure is initiated with absorbable 4050 monocrystal or vicryl. The trim technique is further divided into either a rim, a hybrid, or a barbell look labiaplasty, depending upon the amount of tissue that you are excising. The wedge technique was championed by Dr. Gary Alter and preserves the natural edges of the labia, resecting only wedge or V-shaped excision of most protuberant part of the labia minora. But the disadvantages are longer operative time, steep learning curve, required surgical expertise, and more chances of wound dehiscence. Markings are done when the patient is in the lithotomy position and before the local anesthesia is infiltrated. So I do all of my procedures, either it is labiaplasty or whatever, but everything is done in local anesthesia. So the important point here is that we should mark our planned site of incision before infiltrating local. Otherwise, the field will be distorted and it will be very difficult for us to carry out an aesthetic procedure. A V-shaped drawing is made, we should be centralized around the most prominent portion of the labia. See in this picture, you can see that this is the most prominent part, and you can either make a V like this, or posterior wedge excision can be there, anterior wedge excision can be there. You can excise it anyways, but it should be on the most prominent part. And the degree of excised tissue after excision, what we have to achieve is a straight, non-redundant labia that is approximated under no tension. The subcutaneous tissue is separately stitched using 4050 monocrystal or bicryl, and the medial and lateral labial edges are reapproximated separately. So it is important. A layered closure is always preferred over a single layer closure. Multi-layer closure should be used to prevent wound dehiscence and other complications. So ultimately, what we achieve is a small transverse incision line on the leading edge of the labia. Demucosalization is done in patients with very atrophic thin labia minora, where only minimal amount of labial tissue is needed to be excised, and both the medial and lateral sides, see, it's similar to the wedge excision, but we are not removing the submucosal or subcutaneous tissue here. We are only deepithelializing the part. But this can interfere with the labial blood supply, and it results in holes and gaps. You can see here, this is called fenestration. It's a very common complication after deepithelialization and demucosalization technique. So what we have seen till now is the edge excision is technically simple. It is adaptable and accessible for all labial sizes and shapes, and wound dehiscence rates are rare with it, so it requires less revision, but removes a lot of labial edge. So edge scalloping and edge scarring complications can be there. Whereas wedge excision preserves the labial edge and eliminates the possibility of scalloping or scarring. And it has a steep learning curve, so wound dehiscence rates and revision techniques are more commonly used for wedge excision procedures. Contraindications include body dysmorphic disorder, severe anxiety, history of severe intolerance to pain, narcotics, other drug abuses, medical problems, uncontrolled diabetes, heart diseases, or back injury. Complications like in any other surgery can lead to infection, hematoma, scarring, wound dehiscence, nerve injuries, asymmetry in both labia, and delayed healing and persistent pain. Now coming to the second technique, surgery, vulval surgery, aesthetic surgery, is clitoral hood reduction. So this is the surgery to reduce the clitoral hood area aesthetically. It is also known as hoodoplasty, hoodectomy, or clitoral trimming and hood resection. So clitoral hood varies greatly amongst the individual. The inferior border extends down to the you can see in the this picture, the inferior border of the clitoral hood merges with the labia minora, and laterally the hood is bounded by the interlabial sulcus. The clitoral frenulum, this part, this thin part is called the frenulum. This is the part of the labia minora that extends and joins with the clitoris and begins medial to the attachment where the hood is attaching. It begins medial to the attachment of the clitoral hood. The length of the hood varies from 2 centimeters to 6 centimeters. Indications of clitoral hood reduction include revision for patients who had prior labiaplasty without hood reduction, or with patients of hood hypertrophy, pseudoclitoromegaly, in patients with buried clitoris in lichen sclerosis, or hood tumors and abscess. Again, like labiaplasty, there are various techniques of doing it. The most commonly used are the classical method, inverted V-plasty, and inverted Y-plasty. So in the classical method, the longitudinal incision is placed along the interlabial sulcus and the redundant tissue is excised from this area. The advantages of these techniques is the incision scar is hidden in the interlabial sulcus. You can see here the scar, once the edema is gone, the scar won't be visible. So there is no post-operative sensitivity in this area. Inverted V-plasty was again popularized by Dr. Gary Alter, and the incision starts from the interlabial sulcus, and both the incisions are joined in the clitoral midline, and excess tissue is removed along the incision line. In the inverted Y-plasty, first we have to make an inverted V-plasty, and then with the longitudinal central incision above this junction, the excess tissue in the central area are removed by advancing the anterior commissure, and sometimes even higher. We can go higher up depending upon the site of what we have to remove. It is used for removal of tumors of the clitoral hood and excision of small fistulas. Contraindications include same unrealistic expectations, vulvovaginal infections, inflammatory diseases, coagulopathy, smoking, untreated psychosexual conditions of the patient. Post-operative care for both labiaplasty and clitoral hood reduction include icing for first 2 to 3 days is very important. Standard antibiotic and analgesic regime should be followed. Irrigation and pad drying after defecation and urination should be explained. Showers are encouraged, but just the soaking of the incision part should be avoided. Like she should not use public pools or hot tubs or sauna baths for 4 weeks. The physical activities should be limited for next 4 to 6 weeks. So this is a small video here. Just a second. Here I'm doing a linear labiaplasty. So first you have to be sure about your incision. You have to look for the frenulum, identify the frenulum, and 1 to 1.5 centimeters below the frenulum, you can start with your incision. Once you're confident with your plan of incision, by the kissing technique, you replicate it on the other side of the labia. And this all in the planning and marking is done before infiltration of local anesthesia. So once we are confident with the marking and planning of the incision, we proceed with the cutting, and cutting can be done, as I said, with either you can use a scissors or scalpel, or you can use, if you have energy-based devices, CO2 laser, radio frequency device, you can use anything. But I prefer using energy-based devices like CO2 laser and radio frequencies. I do all of my cases with these only because you can see here, it's very fine. The cutting is very fine and very layer by layer. The cutting is layer by layer. It's not acutely cutting the tissue. So it's not, the thermal injury is also low. And the fineness and the aesthetic results achieved after using energy devices are more as compared to using scissors or knife. We can use electrocautery for achieving hemostasis. It's a very important step that you should achieve proper hemostasis before closure of your wound, because the complication, as I said, hematoma formation, if it at all happens, then it will disrupt all of our sutures and will also affect our surgical results. The aesthetic results will not be as appropriate as desired. So I've done an inverted V-plasty for this clitoral hood reduction. And the suturing is done in more than 2 layers if possible. You should avoid suturing in single layer, because with that proper aesthetic results and hemostasis both won't be achieved. So here I am using 40 Vicryl for the deeper suturing, deeper part of the clitoral hood, so that proper hemostasis is achieved. And the superficial layer also I'll be using 40 or 50 monocryl or Vicryl. The superficial stitches are just interrupted stitches for the approximation of both of the skin margins, so that the result is aesthetically more pleasing. So all this edema you can see here, it's due to the inflammation and due to the local infiltration. Everything subsides by maximum 6 weeks to 2 months. And this you have to explain to your patients also, that whenever she's undergoing a labiaplasty, the maximum result or the end result will be achieved after 6 weeks to 3 months only. So you can see here, it is looking very engorged and very not very aesthetically pleasant. But once you are completed, and once after 2 months you see the patients, all the edema has gone and the results are great. So these are my before after images. And why I'm showing you this, because this is important. The photography carries a different importance in aesthetic practice. You have to take images at each and every visit of the patient, so that it's beneficial for you, for other patients counseling also. Now coming to perineoplasty, It is a surgical reduction of the width of the perineum. As you can see in the image, initially 4 fingers were I was able to insert, and now I'm able to insert only 2 fingers. So I've reduced the width of the perineum. Perineoplasty is indicated for episodic scar revisions, vaginal gaping problems, skin tags, lack of pleasure during sexual intercourse due to introital enlargement, perineal rupture caused during birth or other trauma, marking the perineal area flatter and more aesthetically pleasant. You can combine perineoplasty with your other labiaplasty or other surgeries to make it aesthetically more pleasant. Speculum examination should always be done for some local infection. Clitoral and bulbocavernous reflexes should be assessed before going for the surgery, and bladder hypermobility and rectocele examination or rectal examination to rule out rectocele should be done to give the patient a more holistic approach, and treating all her problems in a single sitting should be preferred choice. This perineoplasty technique is very simple. You have to insert your 2 fingers into the vagina of the patient, and with your non-dominant hand, whether right or left, and with the dominant hand, you have to compress your labia, the patient's labia majora. And wherever the labia majora meets, the 2 labia majora meet, you have to mark that point. So these are the points which I have marked, which this image shows. I have taken this from Dr. Red Ellen Sott's book. This is not my patient, but this is how we mark the patient. And 2 marks are done where the labia majora meet. We have to mark those points, and then other mark is applied on the external anal sphincter. This is our lower limit. We don't have to cross it. And the 2 marks are then joined by a smiling incision or a smiling line, so that we can easily achieve an aesthetic look for the patient. And internally also, you can see here in perineoplasty, we have to go up to the hymenal ring, not beyond that. It's important. Vaginoplasty is different. Vaginoplasty is vaginal tightening procedures, which we do. We go up to the ischial spine. Whereas in perineoplasty, we have to just go up to the hymenal rim and not beyond that. The incision is carried deep into the subcutaneous fat to create a flap of even thickness. And starting at the apex of the suturing is done in similar way as you close your posterior pelvic floor repair. You start from the apex, and with continuous running sutures, you approximate the posterior vaginal wall. But here, because it is an aesthetic procedure, you should take care of the symmetry throughout your complete surgical procedure. Once you reach the bulbocavernous muscle, you have to suture both the sides bulbocavernous separately. Transverse perineal muscles are taken care of, and then finally the skin is sutured. So ultimately, you are closing it in 2 to 3 layers at least. Perineoplasty, colpoperineoplasty procedures should be deferred in patients who plan to have children through vaginal birth in the future. And patients with infections and underlying skin disorders or other pathology of the vulvar region should be contraindications for this procedure. Post-operative care is similar to posterior pelvic floor repair. Area is washed with soap, and surgical pad is applied as dressing. Good antibiotic coverage should be given to the patient. Insertion of anything into the vagina should be avoided until 6 weeks. The stool softeners is a critical point here, and it is important for good recovery of the patient. Patients should be examined at least 3 days, 7 days, and after 6 weeks of the procedures. Complications can include infections, wound dehiscence, pain, over-tightening, under-tightening, and dyspareunia. So again, she was my 45 years old lady. She came for surgical vaginal tightening. I am showing only the perineoplasty part of it. So after measuring 2-finger width, I have planned my incision, and I am using the cautery pencil because this case I did in under local anesthesia. Patient was demanding general anesthesia, so I did it in a hospital setting, and their energy-based devices were not available. So you can use a cautery pencil also. Here I am finishing my incision at the hymenal ring, and hemostasis, proper hemostasis again is very important for any of your surgical procedure. You have to repair, starting from the hymenal ring, repair the posterior vaginal wall. similar way as you do in your posterior repairs. Once you reach the bulbocavernous, you approximate both sides bulbocavernous muscles and transverse perineal muscles. So it's like closure in 2 to 3 layers. This is 2-0 vicule here. It is important that in vaginoplasty and perineoplasty, I don't use 4-0 or 5-0 vicule. We use a stronger suture. It's 2-0 vicule or vicule you can use. And for skin, I use 4-0 or 5-0 vicule for stability and for giving a better cosmesis. So this was immediately after the procedure, and after 2 months, the scar is hardly visible. These are again the before and after images. Again, it's very important. Any case you are doing in aesthetic gynae or aesthetic procedure, either it's peel, non-surgical, anything, you have to take a before-after images. You can combine perineoplasty with labiaplasty or hood reduction, or everything can be done in a single sitting. Now coming to the next surgery is the hymenoplasty. It's a reconstructive surgery, also known as hymenorrhaphy or revirginization. And the purpose is to return the perforated hymen to its original form and provide bleeding that imitates the first night during sexual intercourse. It's a mucosal fold located 2 to 3 centimeters beyond the vulval entrance and has different anatomical variations. The optimal diameter has not been determined yet, and so there is no standard hymenal appearance to produce or reconstruct. It has more of sociological role rather than functional and aesthetic importance. There is no valid scientific indication for hymenoplasty, and it is performed primarily for cultural indications to conceal any history of premarital sex from an intended future partner or to celebrate a second honeymoon. The patient should always be informed that the repair has no direct medical benefits, and the absence of the hymen or failure to bleed is not necessarily a sign of previous intercourse. And around 30% of the women do not bleed with initial sexual penetration. Repair of sufficient strength may necessitate hymenectomy or surgical transection, and no specific genital finding is there to distinguish prior sexual abuse from non-abuse related conditions. So if you explain everything to your patients, if some intelligent patient is there, she might differ from the surgery. She will understand, okay, this is not a very necessary part of life. So in a way, you will help your patients. Again, there are many surgical techniques. I have tried everything in the last few years: flap techniques, surgical adhesions, luminal reduction, suture-only technique. I'm not going into detail of these techniques because every technique has its own pros and cons. Finally, what I have learned is hymenoplasty with VIT technique, that is vestibulo-introital tightening, described by Dr. Ezerdak from Israel, is the best technique for me. It is working for me. So I'm describing this only. A diamond-shaped incision to the vestibulum is given with the base in the posterior midline and superior corner is 2 to 3 centimeters high above the hymen. The angles are accommodated according to the degree of tightening, and layered closure is done from apex downwards, involving the vaginal mucosa. So as I said, I do all of my cases under local anesthesia. So you give a local anesthesia first, make the patient comfortable, and then catch hold of the remnant hymenal tags. You assess the degree of tightening that is required and excise the hymenal tags. Then similarly, like posterior repair, you open up the posterior vaginal mucosa, excise the redundant part, and again close it like you do in posterior repair. So it's just a mini perineoplasty, you can think like that. So start from the apex, the suturing is continuous. Again, 4-0, 5-0 sutures are used in these fine surgeries. And you have to, again, take care of hemostasis, and the vaginal mucosa is separately closed. You can, if it is a deeper incision, you can close submucosa separately. Once you reach the hymen, the tags are, both sides of the hymen are sutured separately, not in the mucosal stitches. Then some stitches also lie on the vestibular part. That's why it's called as vestibulo-introital tightening. It also gives a tightening, apart from hymenoplasty, this gives a little bit of tightening effect also. So you can see here, the vestibule also has 2 or 3 stitches. The complications include risk of distortion, over-vigorous repair with secondary dyspareunia, inhibition of penetration, separation of incision, additional defects to the hymenal ring after the surgery. If surgery fails, will cause a damage to the patient, and failure to bleed is a common complication. Post-operatively, gentle irrigation after urination and defecation and pad drying is important. Patients are encouraged to take showers. Most of them, they refrain from taking showers and keeping the wound clean, but you should encourage them to take showers. Limited physical activity with no exercise for at least 6 to 8 weeks, and patients are instructed not to insert anything into the vagina until her marriage, and not even to inspect her wound by herself, which might cause the disruption. So these are again the before and after images. I have preserved every image of every patient because they might turn up after 2 years, 3 years with anything. Then you need to refer to your previous images that what repair you had done, because you might change the technique in every patient. Now coming to labia majora plasty, the labia majora are two prominent cutaneous folds running from the mons pubis and merging at the perineum, and they are differentiated from the labioscrotal fold and correspond to the scrotum in men. The normal length of the labia majora varies from 7 centimeters to 12 centimeters, and they are separated from the labia minora by a discrete line, the interlabial fold. This is the interlabial fold, and as you should have by now understood that this is the important landmark for labia minoroplasty, clitoral hood reduction, and labia majoroplasty also. With aging, skin relaxation, stretching, pregnancy, weight gain, weight loss, the labial skin can become redundant and can protrude. The prominent labia majora may be problematic because they can cause embarrassment due to bulging while wearing tight-fitting clothes, swimsuits. It might cause functional problems with sexual intercourse, poor hygiene, and physical discomfort in the genital region. So the common indications include cosmetic concerns.
Mayuri ma'am, ma'am, actually your time is up.
Just 2 more slides, ma'am, 2 or 3.
Yeah, sure.
Thank you. So in cosmetic concerns, there is desire for smoother or more symmetrical appearance, reduction of excessive tissue. Functional concerns include discomfort during the physical activities, irritation from clothing, and difficulty in maintaining a proper hygiene. Vulval lesion, dystrophy, any infection is a contraindication. So markings, again, a vertical line is marked beginning at the top of the clitoral hood and in the labial crease down to the level of introitus. Then you identify the most prominent part of the labia majora, and a semi-elliptical mark is made from the top on the most prominent part of the labia majora. Excision should be a moderate amount. You should not excessively excise the labia majora, because on both sides, if you excise too much, it will give a gaping look to the vaginal opening. Only skinning incision is needed in most of the patients who do not have unduly large underlying fat pad. If there is a large underlying fat pad, then we need to resect the fat pad also. So tension-free multi-layered closure is the most important part of the surgery, and so suture sites may heal over the next 6 weeks to 3 months. Post-operative care is almost same, and complications again same as any other surgery. So to conclude, it is impossible to define the ideal aesthetic landmark for the external female genitalia, and it requires excellent judgment on the part of the surgeon and full communication between the patient and the surgeon to provide the best outcome. Surgical techniques depend on the patient's anatomy, preferences, and the surgeon's expertise, as well as the excessive resections can lead to disastrous results that might not be correctable. So it's always better to undercorrect, and then you can always revise or refine and go for more resection later on if the patient is. Thank you.
Thank you, Mayuri.
Thank you so
You have
much,
done-
Dr. Mayuri. Yeah. I think we are already running late. So anybody who have any queries, please send it in the chat box. And Mayuri, can you just mass type their answers if you have any, if the delegates have any questions and queries in the chat box. Okay. So quickly we moving to our last lecture for today. And for giving the lecture, we have our very dear Dr. Milind Sasar. Sasar again doesn't need any introduction, and I would like to invite our chairperson, Dr. Shashi Srivastava, ma'am. Ma'am, can you just please introduce Dr. Milind Sasar?
Yes, Dr. Milind Shah is the president ISCP ARB, and he is many things, and one of the best thing, he is the professor and MD DGO FICP FICOG Naval Maternity and Nursing Home, and he is running his sperm bank. I invite Dr. Milind Shah for his delivering his wonderful lecture. We are waiting for you.
Yes. Thank you very much, Dr. Shashi, for kind introduction. At the onset, I must say big thanks to the conveners, Dr. Ragini and Dr. Narendra Malhotra. It's really wonderful job what you're doing, and that's why actually one need to. One second, are you sure you want to stop recording to the cloud? Cancel, yeah. Yes. So it's the enthusiasm I'm finding amongst the delegates is really wonderful for this certification course of ICOG under aesthetic and regenerative gynecology, actually the reasons. So friends, the very important part which I'm going to show you is about the counseling and the medical legal concerns related to it, which is very important. So I'll just share my slide. Let me just see whether I can share it. Yeah. Can you see my slides?
Yes, sir.
Yes, sir, it's visible. Sir, please make it full screen.
Yeah, I'm doing that as well. It is not happening. Yeah, now it's full screen.
Yes, sir.
Yeah.
Yeah.
Friends, thanks to the entire team of Foxy and ICOG, Dr. Jaideep, Madhuri, Parul, Sarita, Sheila, Parag, and Charmila, and the coordinators. Yes, the Apurba, Vidya, and the all other my good friends. It's indeed pleasure to tell about this counseling part because friends, we have realized a lot during this COVID scenario that what actually the things can go actually wrong, what we can do as a best for given situation, and especially when it comes to the cosmetic or aesthetic and regenerative medicine, bringing the patient from consulting room to OT is definitely a big task. And what we learned from all previous speakers, Vidya, Ragini, and Mayuri, is really true. But all that is said and done, the professional ethics is discipline, study of the morality of the any gynecologist or the obstetrician. They have to their patients, to other physicians, healthcare professionals, healthcare organizations, to insurance companies and governments that pay for the patient care, and to society on the basis of ethical principles and virtues. The demand is increasing. As you can see for this certification course itself, so many people are now finding it a very interestful topic. And that reminds me of our first conference we had again with Ragini at Leela Gurgaon. And eventually then we did it in the first time in Maharashtra in Sholapur, where so many people they came in person to attend that conference, Blossom, and then people were happy to understand about the various aspects of aesthetic and regenerative medicine. There are actually super specialization fellowship training programs, and nowadays there is even MCH available, but there are a lot of improvements which are definitely needed because it needs a specialized training in this particular sector. There are numerous reputable certification and programs actually in the Western world, and slowly it is getting percolated to the Asia Oceania continent as well, whereby definitely actually we can make major changes in this particular field. We need to tell them not only of the surgical but also non-surgical therapies, and we need to give the certification of the training and the new programs we can inculcate to teach them as well. The genital plastic surgery for women has always come under scrutiny, and that has been the topic of discussion in the news media, online, in the medical journals. I remember then I used to fly with Kingfisher. I used to always find those advertises, and people used to always, comment on those particular advertises. And that's why I thought that there should be some measurable standards of the care. There should be some evidence-based outcome norms and standardization, either nomenclature or the training requirements. There's always concern raised by both the entities as well as the organizations which need to complete. So for that, what is required to have the professional ethics of the uh, uh, any particular specialty, and that professional responsibility model, drawing on evidence-based medicine, the based moral philosophy of their time. The first time John Gregory, and then after that English physician Thomas Percival introduced in the history of medical ethics. The ethical concept of the physician is a professional rather than an entrepreneur. Quite often, when I mention about the advertises, people used to think that it is not the service, it is not the profession, it is becoming something like a business. But that's not true. One need to see that there is good advocacy of those particular availability of services, which probably people may not be knowing. I'm going to tell you during this counseling and the ethical consideration talk certain stories as well, which I myself actually seen in my OPD or in my hospital. These three commitments of the all physicians one cannot forget: the competence in the clinical practice, the primacy of the health related interest of the patient, and the secondary status of the self interest and the interest of the third parties to the physician patient relationship. Evidence based medicine is a public trust that exists for the common good rather than the protection of economic, social, and political power of physician. And that's why one need to have a good understanding of those ethical considerations of aesthetic gynecology as well. One has to respect for the autonomy obligates of the physician to empower the patient to make informed decisions about clinical management of her condition by providing her with an unbiased presentation of information about the all alternatives whatever are there, could be non-surgical as well, clinical benefits and risk of each medically reasonable alternative, and to support her decision making by telling her what actually is required. Let us take the example. Just now we saw the wonderful videos and the pictures shown by Mayur of the hymenoplasty. You know, friends, many girls and the ladies, they come to us, they say that it has already got rupture. But we know that it could be because of the non-sexual cause as well. But still, they insist that we need to repair it again. You know, maximum requests come from the Arab countries where it is not actually legal. Still they ask for it because the woman's actually the career is definitely important as far as actually her life or the marital life is concerned. The extreme which I have noticed that inserting a gelatin capsule filled with blood like substance that will burst during intercourse, simulating bleeding, what even Mayuri was mentioning in her actually talk, that that is what actually the requirement is. And that's why unless that happens, that particular delicate membrane is declared that it was not intact, and her she becomes a whore rather than a pious lady. You know, friends, when I read about all those things, I came across this particular news and I was shocked. I was thinking, yes, probably it must be more common in the Arab countries. But no, even in rural Maharashtra, you can see here it is in Marathi, but what they do, this is a tribal population. What they do, they ask actually the couple to perform at first night. They put a the white bed sheet, and unless and that until that bed sheet has the blood clots, that particular girl is declared that yes, she was virgin, and otherwise then they say that the marriage will be broken. So when I read this news, I realized yes, it is not only the affluent class or a particular class. Even the tribal people also, they definitely need actually the counseling. They need actually the to understand what all that is available. So role of counseling and addressing patient expectation is very very important. Important is also giving taking a good informed consent, and of course discuss of all potential risk and benefit. When I said so, let me tell you one another story of similar sort. We always say that breast is a very symbol of womanhood and very beautiful organ, and women always and always they want to have the lot of addressing toward the breast shape as well as the contour as well. But you know, this is a lady, a politician's wife. When she delivered with us, went to another city for her further care. She got abscess in both breast, and these were the incisions were taken. There were three stitches taken in that particular procedure, and I was surprised. I thought whether I am wrong in understanding, because we all were knowing that we never take the stitches for the breast abscess. I asked many plastic surgeons, I asked many surgeons as well, is this a new actually thing? But then I realized no, it was not true. But that lady suffered like anything because she needed a plastic surgery again to overcome these particular scars. And that's why all complications, all other things need to be definitely told. Same is applicable to the PRP therapy, stem cell treatment. because managing patient expectation and ongoing communication is very important. We need to tell what actually we are going to achieve. Especially with rejuvenation, what I have noticed that the patients, they always ask whether it is going to be a lifelong, whether I need to do it again and again. If it is again and again, then what is the use of it? We always tell our patients that now you have to please tell me when I'm going to do certain procedures on you, your aging process I'm not going to halt. The aging is going to go with its own pace, and then we need to the repeated treatment as well. I give them the example of the facial. Like I always tell them, do you do once facial and then you go home and you never go to the beautician after that? So in similar way, certain procedures, yes, they definitely need repetitive actually procedures, which again need to be told very clearly. And for that, one need to have a proper legal and ethical consideration. It's also important to keep the patient confidentiality, documentation, and liability. Quite often I notice that patients, they're always afraid. They feel that whatever they're going to do in our chamber is going to get disclosed to the other patients, or sometimes their other family members, they come for some or other ailment and they will be declare about this particular procedure or the fact. But we need to tell them that it is a routine that not only for the aesthetic gynecology, but also for other procedures, the confidentiality is always and always maintained. And then whatever we are going to do, we are going to document it very clearly, because if unless and until we don't put it on paper, there is every probability that the patient may go to the next door consultant, and probably he or she may get misunderstood about the procedure done. She may say some actually the funny comments as well about that particular thing. That's why, friends, it's always essential to see. Now, let me tell you the example of this feminizing genitoplasty, which is normally done for the Prader scale 4 of congenital adrenal hyperplasia. Here in our country, we always say that the surgery need to be done until the everything is, if she's a salt losing category, medically stable, she should be informed of the raised benefit. But in Western world, they say it is adolescent age. Then only you are supposed to do, because probably that particular woman or the girl wanted to live like that with those actually genitalia like that. And that's why here our parents take decision, but in Western world, the individuals, they take decision about the surgery. So all those aspects, especially those who are practicing in various countries, need to understood that what actually one need to do. The risk of the litigation is always there, because there are always people who can instigate them and saying that this was not the required surgery done on you. And where what is more important is you'll have to again put it on record whatever you have done, and suppose that is with you, there is definitely going to give you the protection from the medical legal issues. One need to discuss about the outcomes and the lessons learned in certain cases as well, with not only patients but your own colleagues as well. And that's how I'm going to tell you the story of this particular lady who got a small labial cyst. And when she came to me, we realized that she was actually visited almost 2-3 gynecologists, and everyone is to say that nothing is required. It is a very small actually the cyst in that particular labia. But to my surprise, when she came to us, when our counselor spoke with that particular lady, she told certain eye-opening facts. She told that, doctor, everyone says it's a very small cyst, nothing is needed to be done. I also don't get any pain or any problem. But my husband passes very nasty comments when we perform in the evening, and I want to get rid of that. Please remove that particular cyst. And to our surprise, when we tried to remove it, was chronically infected cyst as well. We realized though there was no at all any pain element in that particular cyst. So one need to understand that what are the patient's concern about that. Quite few of us who are attending this certification course, I'm very sure they must be busy in doing the obstetrics, gynec, infertility, endoscopy, and also they want to do the cosmetic gynecology. Those are the actually consultants who are likely to get very less time for the counseling. It's essential to see that we have a good counselor with us. Like what we have decided that we kept one certified counselor who had done diploma in counseling from the Symbiosis, and we realized it makes a major difference. In spite of all these, actually, the exercises which we do, there are always ethical dilemmas, and then it's always the organizations they can support a lot. I'm very sure the InSarch which we have started is going to go a long way when it comes to these dilemmas and the certain guidelines are concerned. And given time, we are definitely going to come out with the good, actually, the guidelines for the our consultants as well. So friends, finally about the recommendations, what I have told you in the last few slides is just summarizing of that. I could see that so many of the consultants are getting delayed for their work as well as it is getting prolonged, and they want to have the post test as early as possible to save time. So I'm not going to read all those actually recommendations, but what is more important is a good confidentiality, good documentation, and the good speaking and counseling with the patients, which is very, very important when it comes to the aesthetic gynecology or the regenerative medicine is concerned. That always goes a long way to give a justification. I don't know whether this video is going to run. Let me check. Yeah, anyway, this was the video which I wanted to show you, but I think it is not going to run now. And anyway, time is less, so I'm going to say thank you to you. So once again, thank you, Ragini, for this wonderful opportunity. In fact, I flew to Raipur for the ISOPAP conference, and I was wondering, flight got delayed, whether I will be able to make it up. But it's fortune that I could come in time to deliver this particular talk. Thank you very much, Vidya, Shubha, Apurva, and MC Patel for the patience you have kept till the last talk. I understand it's definitely real, actually, the enthusiasm and the zeal we need to have. Thank you very much. Thank you. Thanks a lot.
Uh, Thank you so much, Milind sir, for a wonderful talk. I always love your lecture and your learning, sir. Thank you so much, and thank you because you make it. I know you have been traveling just before 2 hours. Your flight got delayed, and still you. So thank you for everything. Okay, sir.
Thank you. Thank you.
So any remark from the chairperson, Vidya
Excellent
ma'am,
talk,
Sasi
Dr.
ma'am?
Milind.
Thank you, then. Thank you, Dr. Vidya.
Nicely explained
Thank you so
the
much.
value of the
Yeah,
consent.
the whole
Thank you.
session was very good.
Thank you
Yeah.
very much. Thank you, Dr. Shashi.
Counseling and consent, both are
Yes,
important.
important. Yeah, true. Thank you.
So I think we are also already past the time, and our delegates are really waiting for the post test. So without delay, can you just, Gauri,
Yes, sir.
can you just have the post test? Yeah.
Yeah, I've shared the link.
Yes. Yes.
Can you
Please.
stop share?
Yeah. Should I stop? Yeah. All the delegates, please check the chat box, and just your time already has started. Please complete your post test in time. All the very best. Last 2 minutes left. Time up. Gauri ji.
Yes, sir.
Yeah. I think we already finished our post test.
Yes.
There is some queries that they have missed the day one post test. So we are extremely sorry to say it's a rule that you have to attend all the 3 days. If somebody has missed the pre-test, but they have submitted the post test, we can consider. But if uh, a day they are unable to submit the post test, it can't be considered for the certificate course. So for the certificate. So thank you. But you still join because these lectures are so informative and you can learn, I think, and this type of ICOG certified courses we are arranging regular basis. So next time you can join. Thank you
Answers
so
show
much.
करना है सर अभी.
Tomorrow
So-
also there is. Tomorrow also you join.
Yeah. So tomorrow it's also important. And Vidya ma'am, why not all of the faculties, coordinators, if anybody is there, we can switch on our videos to have a group photograph.
Yeah.
Yeah.
सर आंसर्स भी शो करना है अभी.
Yeah.
अच्छा, answers
Please
show
show the
करना है?
answers.
Okay,
Yes.
okay.
हाँ.
Yeah. Yeah, please. You have the answers now, Gauri ji? Yeah, please. So the first question, what are exosomes? I am sure all of I'm sure all of you have answered it. The answer is option A. What does exosomes contain? Again, the answer is A. How do exosome acts? It's again answer A. The 4 exosomes are involved in different biological processes that include all of the above. True or false? All of the above. Fifth question. The sixth question is again option D. All of the above. The seventh one is D, combine of all of the above. We all know from our basic science now, when we are doing PMT and the PG test, when it is all of the above, majority of the time it is the answer all of the above. The eighth, what readjuvant you will use for the vaginal laxity? It's again D, all of the above. What are the exophyte growths on vulva? All of the above. LSA should be treated with? It is option C, laser and corticosteroids and tranquilizing ointment. What is the primary process of counseling in aesthetic gynae? It is answer B, to address the patient's expectations and concern. The question number 12, what is the following is the key aspect of informed consent in aesthetic and regenerative gynecology? The option B, ensuring patient having thorough understanding of the procedure and risks as in other procedures. Next, please. What is the one strategy for managing medical risk in aesthetic and regenerative gynecology? It is option C, thoroughly document patients, consultation and the procedure. Yes, the complications are very less, but definitely no procedure is complication free. So we should be very thorough in consultation and procedure and documentation. The question 14, what is the following is the ethical consideration in aesthetic and regenerative gynecology? It is option B, that is ensuring the patient comfortability and privacy. 15, what should practitioner prioritize when counseling patients in regenerating the gynecology? It is the option C, managing the patient expectations and maintaining open communications. Question 16, which of the following anatomical structure is not typically considered a landmark for labioplasty? It is the hymen. Yes, definitely it's the hymen. In clitoral hood reduction surgery, what is the primary goal of preserving the neurovascular bundle? Because it's contain mainly the clitoral sensitivity. What is the primary goal of surgical vaginal rejuvenation? To tighten the vaginal canal, of course. Next. What anatomical landmark is crucial for identify the correct location of incision of hymenoplasty? It is the remnant of the hymenal ring. Question 20, labia majoroplasty is the primary performed for the functional result rather than cosmetic concern. It is false. Yes, definitely it is for the cosmetic. The next, platelets are derivative of megakaryotypes. Definitely option A. After the first centrifuge, platelets are mostly present in the upper layer. Optimum temperature for centrifuge of the blood to obtain the PRP is 21 to 24. Yeah, there is some misnomer. I think the one is the about the PRP. Can you just option 22? Gauri, can you just no up? Yeah, 22. Question 22. Yeah, this is the answer which given by the expert. We will consider it and we will revert back to you. 24. Concentration of the platelet in PRP is 10 lakhs per ml. But yeah, I know it is a controversial one, but we will revert back to you and we will answer accordingly. If there is some mistake from our, maybe there is some technical mistake, we will revert back to you. Okay. Concentration of platelet in PRP is 10 lakh per ml. Why vulva is most neglected subject for the clinical gynecologist, though it is well covered in undergraduate and postgraduate curriculum. Overconfident on treating it as most of these start with itching and irritation. So yes, definitely this is a cause, but nowadays the people are realizing this. Cause of lymphogranuloma venereum is H. Ducre. The ulcer of Benset disease is very painful. Treatment of choice for the chancroid is erythromycin. What do you know about the lichen sclerosis? It is the chronic inflammatory disease. We will, those who are writing that answer in the chat box, might be there is some technical issue. And if there is some, if we will again recheck it. And if you have correctly, you have answered, then definitely you will be marked correct. What do you know about lichen sclerosis? It is a chronic inflammatory disease. Which type of PRP is the best for the facial rejuvenation? It is the PPRP. I think this is the answer many of ask in the chat box. So yes, I also feel it is uh, the claim idea, but I will revert back to you. And if there is some problem or some, need some correction in the answer, definitely we will do, and we will mark you according to that. So don't worry about that. Thank you so much. I think now, Gauri, I think we finished now.
Yes, yes.
Yeah, yeah. So can we have a picture? Milind sir, are you there? Vidya ma'am. Kazi sir, you can also please join for the photograph.
Gauri, please make the co-host to Dr. Parag Pinwale, sir. He will give the vote of thanks.
Yes, yes.
He has joined, Parag?
Yes, ma'am, yes.
Dr. Vidya has also joined. Yes.
Is there some
Nice to
issue?
No issue.
Everything is coming blank. Yeah.
Yeah, Dr. Parag, welcome.
Yeah, hello.
Hello.
Yeah, sorry, I was
Hello,
held up
Parag
in
sir.
an emergency.
Yeah.
Am I audible?
Yes, sir,
Yes,
you are
yes, you're
audible,
very
sir.
much audible.
Thank you very much. And on behalf of the office bearers of ICOG, thank you, our conveners, Dr. Narendra Malhotra and Dr. Ragini Agarwal, our coordinators, Dr. Apurva Kumar Datta and Dr. Suman Sinha, and of course, all the faculty who participated in the deliberation. And I must thank all the participants also because they have shown a keen interest on this newly developed or developing subject, which would be an OBGYN or gynecology of tomorrow. So happy learning to everyone. And once again, thank you for joining today. Of course, I'm sure all of you must have attempted the post test. And please don't forget to attend the sessions tomorrow and appear for the post test so that those who qualify for the certificate will receive it in due course of time. Thank you very much.
Thank you. Thank you,
Thank
Dr.
you.
Parag.
Thank you so much, Parag sir. And
It was a wonderful session today, I must say. And few of the speakers like Dr. Vidya Panchalia, who is still there. So her deliberation was excellent. And the people have enjoyed the pre-test and post-test. There are some queries about the answers. Maybe they can mail us so that we can solve the
yeah, ma'am, I have already, because previously also there were some queries. So we will take the notes. I have already, jot down those
Yeah.
queries, and we will revert back to the
Yeah.
speaker and the expert about that, and their opinion will be the last one. Okay, so don't worry about that.
Yeah,
It
yeah.
might be some
And
technical error
yeah.
in this
Some
technical
technical
era. Yeah.
error or something is there.
Apurva, what
Some
I
So
can
technical error.
suggest
benefit
is,
will be given to them.
yeah, what I would suggest is whatever are the queries, talk to the concerned speakers, the
Yeah,
faculty,
concerned people.
and then if
Absolutely,
you know you can so resolve them tomorrow in the recap session. That will be really wonderful.
That will be there. And another thing is there is a query about the ICOG certification course. Certification, no, that they wanted to become ICOG fellows.
Right.
So Parag, if you can send a
Yeah, so
link
all,
or something.
no, I think it's very easy. Please visit the ICOG website, www.icogonline.org.
Yeah, that
All
I
the
told
details are
that
there.
I have written in the chat box.
Yeah, and then in fact,
Details are
for
there, but
application of fellowship of ICOG, there is a link. You can click on the link, find out the eligibility criteria, and if you think that you are eligible to apply for fellowship, please do so. The submission is online. Once the office receives your certificates and everything, the office will verify it and revert back to you. And once they revert back, they'll send you a payment link, and one needs to make a payment of 15,500. And then after that, the fellowship will be granted, and then you have an option of receiving it during the AICOG or at the annual ICOG conference. All these details are very much there on the ICOG website. So please visit the website and get to know more about activities of ICOG as well as how to become a fellow of ICOG.
Yes, thank you. But the certificates will be given offline. They will not be given online.
No.
To receive
The fellowship
the
certificates, yes.
Yes.
So in a convocation ceremony, and the last date is 31st of October. So you still have some time in, you can collect more ICOG points. If you have publications, the things are easy, but you still have few months to go before you collect all those points, and do apply before 31st of October so that you can receive it at the AICOG in Mumbai.
I first
Thank you.
congratulate
Thank you.
conducting us a wonderful class
Yes.
on a wonderful subject. Thank
Yes.
you.
Thank you. Thank you.
Thank you. So we will all meet again
Thank
tomorrow at 4 p.m.
Tomorrow. Yeah.
Yes.
Okay, bye.
Thank you.
Bye.
Thank you
you
so
very
much. Thank you so
Good
much.
night.